Okay, good morning. Good morning. Oops, that is upside down. All right. How is everybody? All right, those of you that are joining us virtually, feel free to put your comments in the chat and we will get to them shortly. You guys had chapter 4 for homework, and 4 is a little complex. There's a lot of information in there. Just breathe. It's, as a CNA, you are not responsible for knowing, good morning, Jen. You are not responsible for knowing what organs are in which body system. We don't make decisions. That's not our role. Our role is not to connect dots. Our role is to observe for anything that we see, hear, smell, or feel, and report that to the nurse. Those of you who go on for nursing, you're going to get an entire year into anatomy and physiology because you have to have anatomy and physiology 1 and 2 before you can even get into a nursing program. So you're going to know this inside out, upside down, from the cellular level all the way up. But that's not us. As CNAs, you do need to have a little understanding that the body is made up of various systems. They all work together to make us healthy. And when something is affected in one system, it's usually going to have an effect on other systems as well. Now, the effect may be minor, it may be major, depends. But the systems, because they work together and they're intertwined, we have to understand that if you've got somebody who has, let's say, COPD and is having trouble breathing, and they're on oxygen and they're really huffing and puffing, well, that's going to affect their muscles because they're not getting enough oxygen to their muscles. So they're going to tire out quicker. It's going to affect their ability to eat because as your stomach fills up, it puts more pressure on your lungs and it makes it harder to breathe. So these body systems are not isolated. Does that make sense? We have to understand that they all work together. And that's really what chapter 4 is going over. But what I want you to take out of chapter 4 is what are normal signs of aging? Because remember, as CNAs, we report abnormal. If you don't know normal, it's really hard to pick out abnormal. And that's what we're going to go over this morning. Is we're going to review all of the body systems very, very briefly, but we're going to talk a little bit about normal and abnormal changes as we age. Okay, so that'll be the first part of today's lecture. But first, let me go ahead and get your scores for chapter 4. When I call your name, let me know how many you missed or what your score is. Paula, do you have 2 and 3 for me? Thank you. Olivia. Thank you. Cindy? For chapter 4. Oh, okay. All right. Gabriella C. Melissa? Ariana? That's fine. Fabrice? Thank you. Brianna D. Antonio? Thank you. Gabrielle H. Daniel? Thank you. Drew? Okay. Brianna R. Amara? And Mahala. Thank you. All right. So let's take a look at these body systems. So your body is made up of all of these systems. You've got the nervous system, you have the cardiovascular system, the respiratory system, the endocrine system, urinary system, musculoskeletal, integumentary, reproductive, gastrointestinal, and lymphatic. A lot of systems going on there. And like I said, those of you that go on for nursing will get really, really deep into this. But I want to just do a high level overview here of each of these systems, more or less as a fifth grade review. You learned all this in fifth grade, guys. You did. Now, whether you remember it or not, you learned this in fifth grade. But your nervous system is made up of the brain and spinal cords, and this is kind of the control center of the body. If something happens here, it's going to affect your entire body. Everything is controlled by the nervous system. So it's kind of like the master motherboard of your whole body. Okay. Brain, spinal cord, nerves is what makes up. But as we age, all of these components are going to age too. So in order to understand this, I want to explain to you kind of the aging process real quick. And I'm going to give you an example. Let's say that I want to invent, I don't know, we'll invent Jeremy, okay? So let's say that I've invented Jeremy, and I want to have Jeremy produced to sell. Good. So I've got to find a factory, and I go tour 2 factories. The first factory is about 90 years old. It's outdated technology. The gears are all rusty. It's missing a few springs here and there. It just isn't going to produce real good quality Jermies, but it is available. The second factory that I go tour is brand new, just built, state of the art. Everything in it, new, shiny, works great. No missing components. Everything is automated, works together. What kind of Jeremy is that factory going to produce? Good quality, right? Makes sense. So if I were to be looking for a factory, I'd probably want that new one because it's going to be much better quality, more consistent. Everybody go with me? Your brain is a memory-making factory. So the memories that your brain makes when it's new are much better quality than the memories that your brain makes when it's 80 years old. Because that 80-year-old memory factory is not working so well today. The gears are a little rusty and the springs are missing. It might be functional, but it's not going to give us any good quality. This is why a lot of your older people can forget that they just had lunch and ask you, what's for lunch? And you're like, you just came back from lunch. You just had a sandwich. Don't you remember? No, they don't. Their factory's offline. Not working right now. But they can remember what shoes they wore to a piano recital when they were 12. Useless information, doesn't help us a bit. But the memory that they made, that their brain made when they were 12 is going to stick around a lot longer because it is better quality. Does that make sense? So when we're working with older people, it's important for us to understand that they may not be able to remember what we just told them, but they may be able to remember things from their distant past, and that's what they want to talk about. Well, they want to talk about it because it's relevant to them, but it's also a memory that they're able to access. Does that make sense? So being forgetful can be common in elderly patients, short-term, things that happened recently. Very common, very common. Now, this is different than Alzheimer's. Alzheimer's is a little more pronounced. And what happens with Alzheimer's, it's really a very sad disease, very sad, because you don't just lose your memories, you lose yourself. You lose your awareness of yourself. And that can be very frightening for patients. And if they don't have memories, they have no coping mechanisms. So if they don't have any awareness of self and no coping mechanisms, they probably are going to get combative. Have you ever heard of elderly dementia patients becoming combative? This is why they're fearful. They're scared. They have no memories and no coping mechanisms for that. So our fight or flight is going to kick in. So a lot of your dementia, especially Alzheimer's patients, will either become very combative or they look for an exit, fight or flight. And this is why we usually have locked units for Alzheimer's patients. Make sense? Good. All right. So talk to your patients. The more we talk to them and the more information we give them, the better off their brains usually are. It keeps those pathways good. But what happens in Alzheimer's specifically is that when you make a memory, it's not just like a file, a piece of paper in a file folder in a cabinet. Memories don't work that way. Memories are made up of little tiny snippets of information that we put together into a memory. So in here, people were brewing coffee just a few minutes ago. So it smells like coffee, right? Most of you are wearing black scrubs. We learned about blood pressure, and I have germy. So all of those things are going to go into making a memory about today's class. So you might smell coffee, and it might somehow trigger a memory about today's class. Or you might put on a pair of black scrubs, and a memory about today's class might show up. So memories are actually made up of all these little tiny components. Now, those components can be shared with other memories. This isn't the only time you'll ever see black scrubs. It's not the only time you'll ever smell coffee. So those components are going to be shared with other memories. And you can trace those memories in your pathways. You can think about the smell of coffee and where you've smelled coffee before and the feelings that that evoked. And remember, all of your senses are involved in your memories: smell, sight, sound, feel, and taste. So when you get Alzheimer's, those little pieces remain. You still have the smell of coffee. You still have the black scrubs. You still have germy. What you've lost are the connections between them. So you have a fragment of a memory, but nothing to tie it to. And this is how Alzheimer's patients lose their identity, their sense of self, because the connections get severed. And eventually, Alzheimer's patients will stop remembering how to eat or how to walk or how to interact with others. And that's really what makes Alzheimer's so sad, is that those connections get severed. Now, Alzheimer's is often really hard on families too, because families will come visit a patient who has Alzheimer's and the patient won't remember them. Mom, it's me. Why can't you remember me? You're my mom. You raised me. Why can't you remember me? Well, remember what I said earlier about that memory-making factory. So the memories that that person has of their child is probably when that child was very young. And now they see this person that is not young standing in front of them saying, "You're my daughter?" No, my daughter is this big. Because the recent memories are gone. Does that make sense? Okay. So trying to tell somebody, "Don't you remember?" doesn't do anything. That's not fixing anything up here. It's a better strategy to get them involved in something. Let's get them into an activity. Let's turn on TV. Let's have a conversation. Let's sing a hymn, something. Get their minds engaged in something else. And sometimes those memories will pop back in when they're not trying so hard. Good? Questions? Do you guys understand a little bit more about dementia now? Tonight, you're going to be reading chapter 5 in your yellow book, and it is all about dementia. So I need you to have just a little bit of understanding about this. Now, that term dementia is a very broad term. If I stood up here and said, guys, I am sick today, that tells you I'm not well, but does it really tell you anything? I mean, does it mean that I have a headache? Does it mean that I have an upper respiratory thing? Does it mean I have a sore throat? Does it mean that I have a stomach issue? I mean, that term sick, it just tells you we're not well, but it doesn't give you any specifics. Make sense? The term dementia, brain sick, tells you the brain is not well, but doesn't give us any details. Brain is not working, but we don't know. That term doesn't tell us why. Now, Alzheimer's is a type of dementia, brain sick. Brain's not working. But in Alzheimer's, the connections are severed. In other types of dementia, other things are happening in the brain. So we can have dementia from having a lot of strokes because strokes cut off blood supply to a certain part of the brain. So whatever memories were in that part of the brain, yeah, they're gone. Gone. No longer there. So dementia from strokes is going to be different than dementia from Alzheimer's. And there's other types of dementia too. Jacobson-Crutchfield disease or Jacobs-Crutchfield disease, Lewy body dementia, Huntington's chorea, Parkinson's dementia, multi-infarct dementia. There's a lot of different types of dementia. You need to understand that term just means the brain is sick, but it's non-specific. Good? Good. And then you can just have dementia because the memory factory is offline. It's old, it's busted, it's broken down, not working. So does that kind of make sense? So that's all when your brain is really affected, dementia really affected. That's not normal signs of aging that we would want to report. Normal signs of aging is I walked into a room and I can't remember why. Or I lost a word. Now, this is actually starting to impact me. I went and had lunch with my mom yesterday. It was a great lunch. I had a fantastic time, but I lost a word. I was trying to tell her a story, and I couldn't remember the word. And I'm like, what is the word? It's right there. I use this word all the time, but it's gone right now. And it took a couple of minutes for that word. Oh, that's the word I was thinking of, right? So sometimes this can happen with aging. Walking into a room, forgetting why you're there. Losing a word here or there, and then it pops back in. That's normal. Somebody who has been just fine and all of a sudden can't remember where they are is not normal. Do you see the difference? When we age, it is not sudden. We don't suddenly develop anything as we age. It's gradual. Little changes here and there. If you have a patient who suddenly does anything, it has to be reported. Sudden changes, never a sign of aging, ever. But subtle, long-term declines is normal. So a diminished sense of taste, normal. Normal. Diminished hearing, gradual, over time. Yeah. The ear organs in there just aren't vibrating the way they used to. They're older. Does that make sense? Gradual, normal. Sudden, not normal. Decreased coordination is a big one. Now, it's important that you understand this because you are young. You are young. None of this has happened to you. And you assume that it's never going to happen to you. I know, because I didn't think I was going to get old. I mean, yeah, I kind of thought maybe at some point I would get old. I didn't think like this was going to affect me. And that's how we all think. So you may not have a really good understanding of how this is affecting your patients. And that's why we have to have these conversations, because you haven't experienced this yet. Decreased coordination can have a big impact on your patient. You know when you have a throw rug and it's just this much higher than the floor? Now, you can navigate that no problem because you've got great coordination and your muscles and nerves are all working together like a champ. And you can go from the rug to the floor and it's just this much of a change, but your body compensates, you move on and you don't even think twice about it. But that little tiny change in somebody with decreased coordination can cause them to fall. Just that little change in height in the floor. So throw rugs, are they a good idea with the elderly? No, they're not. Slower reflexes. So if they do start to stumble, they may not be able to catch themselves. Slower reflexes. But this can also lead to injury. If you hand them a cup of hot coffee and it's too hot and they spill a little bit on themselves, well, you would be able to set that coffee down on a table really quickly. You've got reflexes that are in good shape. As an older person, we may have diminished reflexes, which means we got burned, but it's going to take a second for our brain to realize that we got burned. And that means we might get more injured because we're not removing the source of the injury quick enough. So we really have to pay attention to our older patients. And it's up to us who has quicker reflexes or better coordination to keep them safe. Decreased concentration. Yeah. Those of you who already have concentration issues, this is an impairment that will really send you over the edge. When we're working with older patients, you can't just sit them in front of a TV and think that TV is going to babysit them. Because by the time they get through 2 or 3 commercials, they are up wandering. They're trying to find where they should be and what they should do because their concentration is not enough to keep them involved in that. So activities are usually pretty short and focused. You heard me say earlier this week maybe, that routine is very, very important with dementia patients. And this is one of the reasons, because that level of coping can be impaired. But it's not just dementia patients. Routine becomes very important as we age, just in general, because our coping isn't as strong as it used to be. Good? Good. All right. So remember, anything sudden gets reported. Cardiovascular system, this is your heart and your blood vessels. We've talked a little bit about this with pulse and with blood pressure. One of the things that you're going to see as we age is decreased endurance. So you are going to be walking like crazy. You're all over this facility. You are going in and out of rooms. You are working your tail end off for 12 hours. And you're tired at the end of the day, but you can do that because you're young and you've got endurance. Your older patients, they may not be able to walk to the dining room. And that's a problem. Because if they can't walk to the dining room without getting out of breath and getting overtired, by the time they get to the dining room and sit down, they may be too tired to eat. And then what do you think is going to happen if they're not taking in calories? What do you think is going to happen to tomorrow's energy levels? They're going to be lower So this can set up a downward spiral called failure to thrive. So if you notice that a patient is having trouble getting to the dining room, and by the time they get there, their appetite is decreased, their intake is less, should you be reporting that? Sure, absolutely. And maybe we might want to use a wheelchair to get the patient to the dining room so that they have an appetite. Or maybe we need to get physical therapy involved to help strengthen those muscles and improve the endurance. We've got some options here, but we as nurses aren't going to employ any of those options if we don't know there's a problem. And that's what we need you for. Decreased endurance, pretty common. Higher blood pressures, we're going to talk about that a little bit later, what happens inside the arteries as we age. We'll get into that a little bit later on. Prolonged bleeding. Yeah, we just don't produce platelets. So when your older patient gets a skin tear, it can bleed. It can bleed. So pressure quickly is going to be super important. Fragile vein walls, yeah, we've got to be super, super careful with our older patients, gentle, because they're going to be much more likely to injury. Remember, they have that thinner skin. We talked about that. And if they have fragile veins, then it's really, really easy to end up with big areas of under the skin bleeding, or in some cases, out of the skin bleeding because we tear the skin. So gentle is the name of the game. Respiratory, yeah, there's changes here too. Your lungs become less elastic. They don't inflate as well. But even worse, they don't deflate as well. So right now, if you take a deep breath, you're good. Air went in, air came out. But as we age, all of those muscles around our ribs become stiffer, harder to move. The lung tissue itself becomes stiffer and harder to inflate. And then it doesn't let all of the air out. Some of that air gets trapped. And now it feels like you can't get another deep breath in because there's already stuff there. We're trying to pour into a full cup. So sometimes your patients will have a little bit of difficulty breathing. Remember, anything sudden, not normal. Not normal. But over time, you may see these changes. Less endurance, we talked about that, and shortness of breath. Endocrine system. This is a system that gets overlooked a lot. Most people don't really think about the endocrine system too much. But the endocrine system is responsible for all of your hormones. Now, yes, teenagers know all about hormones, but there's a whole lot more hormones in your body than just the hormones we think of as teenagers here. Your thyroid is dependent on hormones that regulates your metabolism or how quickly you burn those calories to generate heat. Your pituitary, your hypothalamus, which controls day-night. And a lot of times your patients, because of these decreases, will have trouble sleeping. How many of you guys sleep more than 6 hours a night? Yeah. As you age, you'll find that starts to decrease. And it's not uncommon for the elderly to only get a few hours of sleep, which means that they may need a nap because they're tired during the day. So there's going to be some changes. Decreased bone density is one of the changes that's related to the endocrine system. And we think about that with the musculoskeletal system, but it all starts with the endocrine system. When you don't have enough calcium in your bloodstream, your body is going to take it from the bones, and that can make it brittle. But there's a hormone that's responsible for building your bones. And if that hormone starts to decrease as that calcium is removed from your bones, there's nothing to help rebuild it. So decreased bone density, very common, and a reduced metabolic rate. Urinary system, this is the one that's going to impact you as CNAs the most. Right here. This is the one you're most concerned about. because you will be helping patients toilet and toilet and toilet and toilet, and it's going to drive you mad because your bladder right now is capable of holding for hours. Hours. As you age, and we're going to talk about this a little bit later in the program too, how this happens, but as you age, your bladder is not going to hold urine as efficiently. The valve at the bottom of the bladder tends to get weaker with age. So your patients are going to have to pee more often, and they're not going to be able to hold it when they have to go. So when you have a patient that says, hey, I have to go, they mean now. Not, okay, let me finish feeding this patient. Yeah, that's not going to happen. By the time you're done feeding that patient, they've already gone. And this is a dignity issue. Nobody wants to wet themselves. This is a dignity issue. So in general, toileting tasks are going to take priority. Now, one of the things that we do with a lot of our patients is we put them on a toileting schedule. That means that every 2 hours, we take them to the bathroom. Every 2 hours. And it's easier on our schedule to keep patients on a schedule than to be running in and out as needed. It helps work it into your schedule a little bit better. Incomplete emptying, that happens absolutely, because when you pee, your bladder actually kind of squeezes to get the rest of it out. Well, it's a muscle. Like every other muscle in the body, you're going to have decreased muscle tone. So we're not going to empty our bladders completely, which means they're going to have to go more often. Decreased muscle tone and controlling the stream as well. Integumentary, this is skin, hair, and nails. We all know about the changes here. We've talked about the changes in skin. Hair usually loses pigment and turns gray or white. You can have brittle nails. We talked about that with hand and nail care. Decrease in subcutaneous fat. We talked about that with washing rules. And decreased hair production is very common. We also get age spots. It's very strange the way this happens because your skin cells have pigment. And this is what controls the color of your skin. But as we age, those cells get a little wonky. And some of them are like, yeah, we're done. We're not giving you any more pigment. We're just done. And others are like, hey, I got extra. Let's put it all here. So you end up with lighter patches and darker patches. This can be of great importance to some of your patients, especially if they're very vanity focused. And the changes in skin pigment can be very, very concerning. Again, sudden always gets reported. Gradual, that's something that we're going to see with aging. Reproductive, well, there's changes there too. There's menopause and there's menopause, decrease in sexual hormones. But you also have things like hot flashes and night sweats. That's going to be due to that decrease in hormone production. And this can interrupt sleep. This can interrupt appetite. This can make people moody. And of course, decreased fertility. You'll see this is interesting. The changes in hormones in the reproductive system is pretty interesting because some of your female patients, when they have this drop in estrogen, will start taking care of baby dolls. They want that. They're seeking that connection. Remember, memories from long ago are going to be prevalent, and this drop in estrogen often triggers that need to try to recapture that. So we don't encourage this, but we don't discourage it either. If we have an older woman who's carrying around a baby doll, it's fine. It's fine. Sometimes as caregivers, though, we think that we should be the parent in the relationship. These are adults. They don't need parents. They do not need parents. If you would not approach a stranger at Walmart who's carrying around a baby doll and say, oh, no, that's no good, we don't do that, then that's not something you should be doing with an individual in your care either. They're adults. Make sense? So let's talk about that a second. If you've got two people in Walmart that are having a verbal altercation, like that's my bottle of ketchup, no, it's my bottle of ketchup, no, it's my bottle of ketchup, you're not going to get involved, right? That's just a verbal altercation, two people, let them work it out, not my problem, not my circus. Now, if one of them starts throwing punches over that bottle of ketchup, then we're probably going to get involved and separate them. And, because, physical violence doesn't solve who gets the ketchup. But this is the same mentality you should have when you're caring for older individuals. If it's a verbal altercation, let them work it out as long as they remain calm and nobody's throwing fists. But if it gets physical, then we have to get involved. Remember, these are not children. A lot of caregivers I'm going to put you in timeout. It's not your role. So be really careful. On the state exam, any answer on the written test, any answer that treats an adult like a child is not the right answer. And that has everything to do with those resident rights. They have the right to be treated as an adult, even if they're acting like children. Good? Okay. Then we have the gastrointestinal system. Digestion slows down, so they probably aren't going to eat as much. They probably won't be hungry as often. And usually, older people want their bigger meals earlier in the day, not at night. So a little different than the way that younger people tend to eat. They probably are going to have decreased absorption of the nutrients, decreased hunger and thirst reflexes. This one gets us in trouble all the time. Older patients will get dehydrated often. One of the things that you're going to see on care plans with older patients is encourage fluids. That means that every time you walk in the room, would you like some water? Did you drink some water? How about some water? You're really going to be encouraging this because they don't get thirsty. The thirst reflex is gone. They don't get thirsty. And if they don't get thirsty, they're not drinking enough. And if they're not drinking enough, they get dehydrated. So this is going to impact us a lot. And when you get dehydrated, constipation always shows up. Always shows up. So that's a whole nother problem that we really don't want to encounter. But this one here is the one I really want you to pay attention to. That esophagus, the tube from your mouth to your stomach, is a muscle. And it has to contract to push food down. Well, like every other muscle in the body, it doesn't work as well when we get older. Sudden changes get reported immediately. But any changes need to be reported so that the nurse can figure out if they're important or not. This one needs to be reported. If your patient, when they take a bite, starts to cough, stop feeding them. Go get the nurse right away. If somebody is coughing when you're feeding or giving them drinks, do not give them any more. Because if they have decreased muscle tone in their esophagus, that food or fluid could be diverted right into their lungs. So this is the one thing that, even though diminished tone is normal as we age, we as CNAs have to stop feeding them and report it to the nurse. Because if you keep feeding them and that food goes into the lungs, that patient's going to develop pneumonia and they probably will die. Probably. Because foreign objects don't belong in the lungs. Musculoskeletal system. Yeah, decreased bone density, decreased muscle mass. We get less bendy. We've talked about that. Decreased strength, inflammation of the joints. We call this arthritis. And man, it is way worse than young people think it is. This is like horrible, horrible. Instability, coordination impairments, those are all very, very common as we age. But again, anything sudden gets reported. Any change is going to get reported, but anything sudden gets reported now. So when you're taking the written test, if the question has a change, the patient develops some change, it needs to be reported. But if the word sudden is in that question, that means that it needs to be reported now, or we have to take action of some kind. Heimlich. If they suddenly are unable to talk or cough, we have to do the Heimlich. If they suddenly fall to the floor, we have to figure out if we need to do CPR. Anything, if the question has the word sudden in it, it requires immediate action. Good? Questions? All right. Lymphatic system. This is kind of the hidden system of the body. This is the recycling system of the body. When you have excess fluid where it doesn't go, like swelling, if you got fluid somewhere that it doesn't belong, your lymphatic system is what collects that fluid and puts it back in circulation. This is a big part of our immune system. Filters a lot of fluid. Big part of our immune system. And we have changes there too, which means your patient is not going to have as good of an immune system as you do. So this is where we kind of got into some trouble with COVID. We kind of got into some trouble with this because during COVID, we shut down all of our facilities. Like people could not come in and visit. We shut them down. And staff members would come and go, but no visitors were allowed. And this affected patients. They stopped eating. Like we lost a lot of people in elderly care from failure to thrive during COVID because they just weren't being visited. They couldn't go to the dining room and interact with anybody else. They were literally shut in their rooms and isolated. And that caused a lot of failure to thrive. But the real problem here is we have to start looking at our own responsibility in this. We know that our elderly patients don't have good immune systems. We know that. It's part of aging. And they're all in one place. We got that too. So we said, okay, no visitors can come in. We're going to keep our patients safe. Sounded like a good idea. The problem is that you are working there and you go in and you work your shift, but you go home at the end of your shift. You also go to the grocery store and you go to the park and you go to all these places and then you come back into the facility the next day. Now, just because we blocked out all the visitors doesn't mean that we've really minimized the risk to the patients because of our habits. Does that make sense? So this is kind of where we got in a little bit of trouble with COVID because we really didn't think beyond lock the door. We didn't think about the risk to the patients. So everything you do outside of work hours is going to put your patients inside of work at risk. Do you think about that? So because of this, some facilities require that their staff get vaccinated for the flu because we don't know where you are outside of working hours. And we don't want you bringing that flu into our patients. If this is a concern for you, this is something you want to bring up during the interview. Do you require mandatory vaccinations for employees? That's a great interview question if this is important to you. But it really has everything to do, not with what you're doing in work, it's what you're doing outside of work and what you're going to bring back to our patients that don't have a good working immune system. Good? Questions? Yeah.
COVID vaccine for CNA?
It depends on the population you're working with. And I can't give you one answer that's going to cover everything. If you're going to be working with cancer patients, then yes. Why would that be important? If you're going to work with cancer patients, why would it be important? Yeah, not only is it not working, we intentionally killed it. That's what chemotherapy does. It wipes out your entire immune system. It kills your immune system. That is the role of chemotherapy. Kills your immune system. And then we have to build it back up. And hopefully we're building it back up with good, healthy cells. But if we've killed your immune system and we have employees that come and go and do things outside of work hours, and we know the patient population has no immune system, do you think that that would be important to make sure that we're giving the highest level of protection to the patient? Pediatrics. If you want to work in the neonatal unit, they have no immune system. None. Neonatals have no immune system. They're like 3 pounds. So would it be important for those staff members to have the highest level of protection?
I guess the question I'm asking is kind of irrelevant, but how do you figure out where to work as a CNA?
Oh, that's a great question. Can you put up the quiz? The healthcare quiz here.
Oh, the personality quiz.
Oh, it's not coming up. Okay. Bless you. All right, I have a quiz for that. So it's free. If you go to 4YourCNA, under CNA training, there's your ideal workplace. And it's 19 questions, takes you about 4 minutes to go through. And it asks you questions about your personality because not every place is right for you. So let me give you an example. How many of you guys think you want to work at a hospital? Okay. All right. How many of you think you want to work in home care? Okay. How many of you are looking at mental health? Okay. All right. So you guys all kind of have an idea of where you might want to work. But have you stopped to think about not just where you want to work, but what work is going to need from you? So let me give you an example of this. My oldest son does not adapt to change very well at all. He is change adverse. When he was little, if I changed my hair color, he would cry. Not good with change at all. Now, if he went to work at a hospital, he would have real trouble because the hospital, you might start out with 6 patients at the beginning of the shift. By the end of the shift, you have 8 patients and only 2 of them are the same as what you started with because patients are admitted and discharged and transferred to other units. And it's just all change. All. So if you don't do really well with change, the hospital is not a good environment for you. Now, on the other end of the spectrum is me. I get bored super easy. Oh my gosh. I can't do repetitive work. If I have to do the same thing every single day, I will go out of my mind. I am a problem solver. That's what I do. Give me a problem. Give me the hardest problem, please, and let me chew on it for a while. That's what I like. So for me, the ICU was ideal. Ideal. Tons of problems. Lots of change. Nothing repetitive. But you try to put me in home care, I will pull my hair out. I will absolutely pull my hair out because there is not enough there for me to do. Just not enough. So you have to kind of think about your personality when you're thinking about where you want to work. Are you the type of person that is super intimidated by a lot of really technical machines? Well, the hospital is not the place for you because that's all we got. Maybe a nursing home might be a better option. Are you the type of person that likes to form deep connections with other people? Are you social? Yeah, well, in that case, you might want to look at a longer term situation so you get to know your patients and it's very routine and you get to spoil them. So you have to look at you, not just the place that you want to work, but also you and how you would fit into that. If you're the type of person that's like, yeah, personal care is okay, but not really my thing, mental health might be a better option. Still do some personal care, but most of it is encouraging others to do their own personal care and keeping them on a schedule. Make sense? So you have to start to think about you and how you would fit into certain settings. And I have a quiz for that. 19 questions. And it is scary accurate. It is scary accurate. I've had a ton of medical personnel take that quiz that are already working in healthcare, and it pinpointed where they work. It's good. And it's free and it's easy. Go take it. All right. But yes, that's the best way to figure out where you should start. One other thing about that, little off topic. One other thing about that, if you get into a place that you're not happy with, if you wake up in the morning, you're like, oh my gosh, I got to go to work today. I hate it. I want to call off. I don't want to work here. If you have that kind of attitude, please do not leave medicine. Find a new workplace. Because in most cases, it's not what you're doing, it's who you're doing it with that you're reacting to. It's your coworkers. So some people get into healthcare, they start to work and they're like, oh, I hate this. I don't want to be here. I don't want to do this. And they leave healthcare completely. And that's not the right answer because the right workplace might be the next one that you try. So don't give up on healthcare. Try a couple of places first. So this is something I did not tell you, but let's get into this really quickly. Do not mention names. Let me just start out by saying that. Do not give me any names. But does anybody here have a hospital that you would not go to? Okay, that you've had a bad experience at, or you had a family member with a bad experience. Okay, don't mention the names. But most of you have a negative experience encounter with a healthcare place. And it was so bad that it made you decide, I'm never going back there. So I want to talk about that really quickly because I'm going to kind of rearrange your thinking a little. When you're talking about, I don't like, let's just hospital ABC down the road. I don't like hospital ABC. Am I talking about the parking situation? Am I talking about the color of the outside of the building? How many windows it has? Am I talking about the inside of the building? I'm probably not even talking about the food. I'm talking about the people. Now, remember, healthcare is very transient. The people that you encountered at that place when you had a negative experience probably aren't even there anymore. They probably went to another hospital. Does that make sense? It's usually not even the doctors and nurses that caused you to have that opinion. It is usually direct care staff, us. My call light wasn't answered. I didn't get the pain medication. My IV got disconnected and nobody put it back. No one helped me to the bathroom. My food tray was delivered cold. Those are the things we focus on. And those are the things that are 100% in your control. So when you are caring for patients, you have to remember that you are the one that they are going to base their opinion of the entire facility on. The whole facility. I didn't like that one CNA, and I'm never going back to that hospital. That's a huge amount of responsibility on your shoulders. You are the one person they are going to hinge their entire experience on. So that's why we spend a lot of time talking about how we're treating the patient in this class. We talk about resident rights and patient rights because that patient is going to form their opinion based on you. Does that make sense? So if you're in the wrong workplace and you hate your job, how many of you guys have seen a healthcare worker that hated their job? It comes through. It absolutely comes through. So if you're in the wrong workplace and you hate your job, leave. Go find another workplace. Everybody's hiring. Find a new place to do nursing. Don't take it out on your patients. Okay? Don't leave healthcare, though. We need you. We need you. All right, so let's review pulse. Pulse is a measurement of how many times a heart beat over 1 minute. So we're always going to support the arm. It's always reported over 1 minute. Normal is between 60 and 100. We're going to use our fingertips, not the flat part of our fingers. We're going to get the radial pulse, which is at the top of the wrist, the thumb side of the wrist, not the bottom by the pinky. We'll say start and stop for the test so the evaluator keeps up with us. And we have to make sure we document. Dressing a resident with a weak arm, we always ask about clothing preference. Patients have the right to choose their own clothing, and we want to get that clothing before we undress them so they're not laying there naked. We're going to lift from below with a flat palm. We support all joints when lifting. We undress strong arm first, dress weak arm first. We're going to adjust the clothing for neatness and appearance. Don't force movement. Be careful not to bend fingers back, that type of thing. Put all dirty items in the hamper, never on the floor. Remember, nothing goes on the floor. Nothing clean, nothing dirty, nothing on the floor. And the call light will go in the stronger hand. Hand and nail care, we're going to wash whatever the care plan tells us to. 1 hand, 2 hands, whatever the care plan tells us to. We'll support that wrist and arm at all times. We're going to soak the hand in water. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to put the hand on the towel and clean under the nails with the orange stick, wiping it off in either direction. We're going to use the beveled edge or the slanted edge kind of as a scoop. And then we're going to file the nails in one direction. We'll put lotion on last and then wipe it off. Make an occupied bed. Patient always has to be in the center of the bed at all times. Whether they're on their back or their side, doesn't matter. They have to be in the middle of the bed. But to change an occupied bed, we're going to remember clean rolls toward me, dirty rolls away. And if we have the patient on their side in the middle of the bed, they take up less of the bed, less of the mattress, smaller footprint, and it makes this process a little bit easier. So we're going to have them scoot toward us, roll to the middle, change the bottom sheet, and then back on their back, go around to the other side of the bed, scoot them toward you, roll them away, and take that dirty bottom sheet off and smooth the clean one. Minimize wrinkles. We're going to talk about that today. Make hospital corners after you put the top sheet on. Nobody cares how. Get those corners off the floor. Replace the pillowcase. Minimize time without the pillow. Opening should face away from the door. We learned range of motion. Remember that CNAs do exercises to retain function, not regain. We're not trying to improve anything here. We're going to lift extremities from below with a flat palm, 2 points of support near the joints. We're going to move slowly and smoothly, returning all the way to the start position. Flexion, extension, up, down. Abduction, adduction, side to side. Rotation around. We're going to follow that care plan. Look how much you've learned. Good job. Is anybody lost yet? We good? All right. Let's get into today's lesson then. Let's go to page 138. So 138 tells us an overview of this particular skill. The skill is called change position to supported side lying, which is a mouthful. We're turning a patient on their side. That's what we're doing. We're going to prop them there with pillows. That's what we're doing. This isn't a hard skill. But if you prepare a patient properly, when you turn them on their side, if you prepare them right, there's no stress on you or them. You can turn somebody 3 times your body weight. Easily. Easily. As long as you know how to prepare them right first. If you've just got a patient laying on the bed and you try to grab their shoulders and their hips and kind of move them over, it doesn't work. Does not work. You will hurt yourself or them. So proper preparation here is key, and we're going to get into that in just a few minutes. This tells you all the principles involved, and they're all spelled out here. We already know all this. We know all this. We know to follow the care plan. We know that every skill starts with an opening, and every opening starts with a knock. We know we know to evaluate if we need gloves. We know we have to use a barrier on the table if we use supplies, and we're going to get that first. We know to use a privacy blanket if the patient's uncovered or undressed. We know that we can't hold linens against our uniform. We know that if we're going to turn a patient on their side, we have to scoot them toward us first, so they're in the middle of the bed. And we know how to do our closing. There's nothing new here other than this. This is your short version of the skill. I have a video for that. And down here is your test-specific information. So somebody with your level of experience should be able to do this skill in how long? Within 8 minutes. Guys, you're turning somebody on their side. Putting some pillows there to hold them in place. That's it. They give you way more time than you need here. Way more time than you need. Don't rush through this. So we talked a little bit about this in the last class, but let's get into it just a little bit more. Care plan at the top, page 139, tells us to position the resident on his left side. So what side am I putting him on? What if the care plan said right? So we follow the care plan. Remember, for the test, some of them are going to say left and some of them are going to say right because they're deciding, do you know how to? Yeah, follow the care, read the care plan, follow the care plan. That's what the test is all about. 100%. Patient requires support to remain on their side and is unable to assist with turning. Let's talk about that. If you remember, on day 1, I taught you it's the care plan, the whole care plan, and okay, this care plan, which we know we have to follow, says unable to assist with turning. Doesn't say they're immobile. Don't make this care plan different than it is. It says they can't assist with turning. It doesn't say they're paralyzed. So you can ask the patient, can you scoot toward me? Doesn't say they can't. So for the test, you're going to ask them, can you scoot toward me? Now, if they can't, if they are immobile, we have to talk about that. What do we do if they are immobile? But this care plan does not apply to that. This care plan just says they can't roll. They can't turn. Don't alter the care plan. Good? Step-by-step instruction supplies down here. Remember, we talked about this. Cribs are designed to keep babies confined, keep them safe until they start to climb out of them. And then they're no longer safe. They're actually much more dangerous because a baby that falls from this height is going to get less injured than a baby that falls from this height. Same thing here. An adult that falls from this height is going to get less injured than an adult that falls from this height. Side rails do not keep your patient safe if they're likely to get out of bed. We have to have a doctor's order for side rails. Positioning rails are different. The half rails at the top of the bed, that just helps our patients move around in bed. It does not restrict their ability to get out. They're not side rails. But when we have an immobile patient, somebody unable to move on their own, that gives us a few changes we have to think about. If a patient is unable to move on their own, can't move on their own, do we need side rails? Why? They can't move. You put them in the middle of the bed, guess what? They're going to stay in the middle of the bed. They cannot move. A lot of people think with immobile patients, we have to have side rails to keep them safe. From what? They're not moving. The problem here is that if you don't understand scoot and roll, if you don't scoot that patient toward you, so after the roll, they're in the middle of the bed, you're going to think you need side rails. Because if you put the side rails up and you just turn that patient, they're going to be right up against that side rail. What if the side rail fails? But more importantly, let's think about that from the patient's point of view. Where do you think the patient will feel more comfortable? Right up against the side rail on the edge of the bed or in the middle of the bed? In the middle. Side rails are not to be used for safety. Make sense? Good. So if you have a written test question that says you have an immobile patient, what is an essential action to take? Side rails is not your answer. Good. Okay. All right. So if we have an immobile patient, we have to think about things, steps that we need to take to keep them safe. So when we have an immobile patient, somebody that's unable to move on their own, we're always going to use scoot and roll so that they're in the middle of the bed at all times, and that keeps them safe. But if they're immobile, it means that they're not able to move on their own, and that sets up a whole bunch of really big problems for our patients. We're going to talk about the skin problems in a minute, but there are other problems that we have to consider. Your body relies on movement for a whole lot of things. One of the things that you have to be able to move to keep in good shape are your lungs. If you're laying down all the time, all of the secretions in your lungs harden along the back of your lungs. And now you can't get a good deep breath in, and you're likely to develop pneumonia just from being immobile. Immobility also affects the intestines because a lot of the food that you eat has to go through your stomach and the small intestines. Now, small intestines are muscle, but they're smooth muscle. They don't contract on their own. Food doesn't move through your small intestines by itself. It relies on your abdominal muscles. So as you turn and sit and stand and talk and walk and breathe and do all of those things, your abdominal muscles are moving food through your digestive system. So what do you think is going to happen to somebody that isn't moving? Intestines aren't going to work. What does that give us? What kind of result do we get? Constipated. Absolutely. Absolutely. So our immobile patients are going to be prone to constipation. So pneumonia, that sounds bad. Constipation, that sounds bad. We also get decreased lung volume, which means they're going to breathe very shallow. And if we don't expand our lung tissue often, it kind of goes to sleep and it doesn't work well. That's a problem. Decreased bone density, that's strange. If you've got a patient who is immobile, their bones actually start to break down. They have decreased bone density, which means they're at higher risk for, what do you think they would be at higher risk for? Yeah, fractures. So if we drop this patient, you might bounce. They're going to break. Good? Well, it's not good, but it makes sense. Okay, muscle atrophy. The muscles actually shrink. And even worse than muscles shrinking are tendons. When tendons shrink, it actually draws two body parts closer together. This is called contractures. So muscles shrinking, they just get smaller. You're less strong. Tendon shrinking changes your whole body posture. Have you ever seen somebody that's like drawn up in a fetal position? That's what happens when we aren't moving our patients. That's horrible. So immobility, not a good thing. Not a good thing. It decreases our immune system. And it also decreases cognitive function because we're not getting good blood flow to the brain because our heart isn't contracting hard. So lots and lots and lots of problems here with immobility. Because of all of this, our patients that can't move themselves have to be moved. Good? If you can't move yourself, you have to be moved. And it's because of all of this. But it's also because of the skin. This stuff you can't see. You can't see any of this happening from the outside. It's all happening, but you can't see it from the outside. What you can see are wounds, skin issues. So we're going to talk about that. In order to understand this, I need you guys to play along. I want you to sit on one of your hands for the next 2 minutes. So put one hand underneath your thigh on your chair for 2 minutes. So you're going to want to pull it out. You will. Don't. Play along because I want to show you something. And this is going to take about 2 minutes. I'll let you know when you can pull it out. Now, when we have a patient that is, there we go. When we have a patient that is immobile and laying in one position, we have pressure points. This is the point of the body that's going to press down into the mattress. Back of the head, tips of the shoulders, lower back, buttocks, back of the thighs, back of the legs, heels. These are all what we call pressure points, areas that are likely to break down. So if we have somebody immobile, we need to be paying attention to all of these pressure points because we have bone that's pushing down through muscle and skin. And we know that we need blood flow to areas to keep everything good and healthy. So when we have bone pressing down on muscle, fat, and skin, it is going to compress the lowest layer. Now, the lowest layer here happens to be blood vessels. So we are crimping off those blood vessels, closing them off. No blood is moving through. What do you think happens to tissue that does not get blood flow? Bruises. Long term, what's going to happen? What happens to anything that doesn't get blood flow? Dies. Yeah, we're going to get blood clots. Yeah, the nerves will make it go to sleep, but ultimately it's going to die. That tissue dies. Now, we're good in medicine. We can fix a lot of things, but we're not Frankenstein. We can't bring stuff back from the dead. Can't bring it back from the dead. If something is dead, it's dead, right? Well, that's what happens here when we have something, weight that's pressing down. We're going to close off those blood vessels. And this happens way quicker than you would think. Go ahead and pull your hands out. Take a look at it. Look close. Do you have color changes? 2 minutes, guys. You have color changes already and you're healthy. But look even closer. Can you see the pattern of the chair or your scrubs imprinted in your skin? 2 minutes, guys. 2 minutes. That's all that took. Now, if you did not move your hand at all, oh, yeah, anytime I put my hands up like that, victory, I get balloons. If you did not move, if you didn't pull your hand out, if you were in the exact same position with your hand under you for 2 days, now we've already cut off blood supply in 2 minutes. What do you think is going to happen over an extended period? It's going to die. Absolutely. And when it dies, it separates. And this is how bed sores occur. This is how a bed sore is born. It's because we had extended pressure in one area without interruption for a significant period of time. And guys, it doesn't take 2 days for that to happen. Bed sores can occur in the right situations in as little as 20 minutes. In as little as 20 minutes. But that's kind of the worst case scenario for most immobile people. We are going to be responsible for changing their position every 2 hours around the clock. That means we're waking them up at 2 a.m. and turning them. It also means we're waking them up at 4 a.m. and turning them, and 6 a.m. and turning them. Thank you very much for all you are doing. I've learned a lot of things from you in the medical field that I did not know. Thank you. Thank you, Helen. I appreciate that. We had changes in 2 minutes, and you're healthy. When we have an immobile patient, we have to understand this, because the biggest risk, now all those other things we talked about are big risks, but the biggest risk to our patient is bed sores. Some CNAs think that they're doing the right thing by letting their patients sleep all the way through the night. They don't want to go in and wake that patient up and turn them. They think they're doing a good thing. And that means this patient has not moved in 8 hours. And when we do turn them, they will have a bed sore probably about the size of my fist that is dead. And it's going to take a very long time, years, and a whole lot of treatments just to get it to close over. We're not trying, healing is not what we're doing here. We're just trying to get it to close over, because that is a doorway in. And it's right up against your spine in most cases. Your spine has your spinal cord, which leads directly to your brain. Is this a good scenario for anybody? This is a really bad thing. So as CNAs, one of the biggest tasks you're going to have with immobile patients is to turn them on a regular schedule. Do not skip this. Do not skip this. Super important. You will have at least one test question on this. At least one. And this just blows my mind. This nursing home CNAs get this. They turn their patients. They do a great job. You know who fails at this? Hospital CNAs. Hospital CNAs aren't turning patients, and it's consistent. Patients will be transferred from a nursing home to a hospital for an acute problem, whatever that problem is. And when they come back to the nursing home, they almost always have a bed sore, because CNAs aren't addressing this. So if we have an immobile patient and you know Immobile patients have to be turned, and there's nothing on your care plan that says, hey, turn the patient. What do you think you should do with that information? Yeah. Hey, this guy's immobile. You want me to turn him? Because sometimes the nurse might get interrupted when they're doing their care plans. Do you think that's possible? Family members come up and talk to nurses all the time. Other nurses, doctors, the phone ringing, nutrition calls to clarify a diet order, social services calls. It's chaos. And I'm supposed to remember absolutely everything that has to go on a care plan. And these care plans are big. So things might get missed. If you know that patient needs to be turned and it's not on your care plan, give the nurse a heads up. Hey, not on the care plan. You want me to do this? And they'll go, oh my gosh, yes. Thank you. Question? Somebody had?
How do you get rid of a bed sore?
There's a whole industry devoted to this. There's wound care nurses, and that's what they do. But we have wound vacs, which is very gentle suction to help stimulate blood flow and nerve redistribution. That's often used. There are dressings. We usually pack it with some sort of a medication impregnated packing tape. We try to keep them covered, so because it's a doorway in. But a bed sore for every, I'm trying to remember the ratio, but for every centimeter of a bed sore, I think it's something like a 2-month healing for every centimeter of the bed sore. I believe that was the ratio. Yeah, so, and it's never going to be totally healed. It's never going to be back to normal because what you're filling it in with is scar tissue, not healthy tissue. So they're bad. They are bad.
I don't understand how you get bed sores.
So when we have, let's just take me, okay? If I lay down on a bed, right, my lower back right here is going to push down into that mattress. My whole body weight is pushing down. So all of the blood vessels right there, all of my body weight is pushing down. So my blood vessels do that. So now I have no blood flow to the skin or the muscles. No blood flow. So those cells die. And when they die, my body goes in and collects them and takes them to the liver to be disposed of. So now I've got nothing there. It's a void. And if those cells happen to be in my skin, it opens the skin. And now I can see right down, either to fat or to muscle or to bone.
So it's just a big wound.
It's a huge wound, right? But here's the problem. If you scrape your arm, you get a big scratch on your arm, you still have healthy tissue around that to knit it all back together. When you have a bed sore, you have completely removed that tissue. The body has taken it away. It died. Body took it away. So there is no healthy tissue around it to knit it back together. Now we have to fill in with scar tissue, which doesn't really serve any purpose but to close the door. Make sense? It's kind of like, think of it this way. We have a door there. The door works great. If that door, if we were to take it completely away, somebody just comes and steals it. Now we got a big opening. Anybody can come and go. So we don't have any more doors, so we're going to put plywood over it. Yeah, it covered the hole, but is that going to let you in or out? I mean, is it going to be functional? Is it going to be as good as what we had before? It might do the job, but it's not going to do it well. Good. But it takes a long time. And oh my gosh, they're horrible painful. Horrible painful. I mean, horrible. Because the nerves are gone. I mean, the nerves have been eaten away. So now you got this little nerve over here, right? There should be a straight line, a nerve that just straight line, right? But because there was no blood flow, that nerve part died. So now you got this nerve over here, and you got this nerve over here, and they're not really talking to each other. So because they're not talking to each other, they're starting to shout at each other because they're not connected anymore. And that's the pain signals. So can you imagine all the nerves around a bed sore just shouting at each other all day, all night? How much sleep are you going to get? Bed sore's bad. Good? Okay. We're going to talk about that in just a minute, but let me address it now that you brought it up. When you pulled your hand out, I had you look at it, color changes, but I also had you look for the pattern of your chair or the scrubs. So anything that's underneath the patient is going to press up into the patient's skin. Now, if it's a wrinkle, now we've got a fold. We've got a change in height. And that change in height is what's going to, the higher part is going to push into the skin much more significantly. So wrinkles are going to increase the likelihood of bed sores. Does that help? Make sense? It's just that change in height. And it's minuscule, tiny, but it's even worse than that. Even worse than that. One of the worst bed sores I've ever seen was caused by a hearing aid. One of the worst bed sores I've ever seen was caused by a hearing aid. Patient's hearing aid fell out, got trapped underneath her, and the CNA wasn't moving the patient. And that hearing aid bit into her skin, bit into her skin, bit into her skin, and actually became embedded inside the bed sore. It was horrible. And it just that, because, I mean, if a wrinkle change in height can contribute to a bed sore, can you imagine a hard plastic? Hi, good morning. Can you imagine a hard plastic hearing aid? How much that would bite into the skin? It was one of the worst bed sores I've ever seen. And they actually had to go in and surgically remove that hearing aid from inside the wound. It was bad.
So, like, when a CNA does something like that, should be like legally held?
Okay, so that's a hard question to answer. And intent is going to play into it a fair amount. CNAs generally are not liable for legal action. It's really the nurse's responsibility to make sure you're doing your job. That, I mean, at the end of the day, that's really what it's about. I have you guys to help me, but it's still, the patients are still my responsibility. So at the end of the day, the nurse really should have made sure that the patient wasn't laying on a hearing aid, and, you know, that the skin was okay, that the patient was being turned, and all of those things. Intent plays a part in this. But at the end of the day, we have to be able to live with ourselves. And if we did something that caused that level of injury to the patient, we really should be doing some of our own soul searching outside of the legal framework. Does that make sense? This is a human that we are responsible for. And even though we may not be legally liable, we are ethically liable. So is it possible that this CNA might have received an invitation to meet with the Board of Nursing about this issue? Sure, because the Board of Nursing may say, okay, listen, this shouldn't have happened, and we got to make sure that this CNA understands what they did wrong so it doesn't happen again. So yeah, there may have been an invitation issued to the staff to go before the board and let's talk about this, but it doesn't necessarily mean that they're going to have sanctions taken against them.
Like, there's no way you're that busy, right? Like, you have to.
Oh, there is. There is. Absolutely. Absolutely. And this is a big topic in today's medicine. This is a huge topic in today's medicine, is being understaffed. Huge topic. And unfortunately, we have two, and I'm not going to get into the politics of this too much, but you've got two competing forces here. You've got administration who is trying to keep their investors happy and rake in record profits. And the only way they can do that is to minimize staff. That's the only thing in their control. That's it. They can't control how many patients they get. They can't control the cost of supplies. All they can control is payroll. So if they're trying to get record profits and the only thing in their control is payroll, they're going to work you as short-staffed as they can. They just are. Now, there's a lot of benefit to being involved in the conversation. Don't just clock in and check out. You need to be proactive. You need to be advocates for your patients. And if you feel that that staffing is unsafe, you need to speak up and say, I have 6 patients that have to be turned every 2 hours. I also have to change them. I have to feed them. I have to, whatever the care plans are for those patients. And you need to bring that to administration and say, it is not physically possible. Make out a schedule. Show them. These are the tasks that are not getting done. Who's doing these? Because I can't. Every minute is accounted for here. And that, no call lights, no emergencies, no nothing. Every minute is accounted for. Who's doing these tasks? And it is appropriate for you to do that because administration does not usually work in bedside care. They don't know. So educate them. Don't clock in and check out if you want to change healthcare. Be involved in the conversation. Does that make sense? But yes, there are times that you are absolutely physically not going to be able to accomplish everything that's on your care plans, and you're going to have to prioritize. You're going to have to. So which do you think is more important? Turning an immobile patient or performing hand and nail care? Turning an immobile patient. Which do you think is more important? Feeding a patient or walking them down the hallway? Feeding the patient. So we have to learn how to prioritize the care that we give to have the maximum impact. If we're going to make decisions, we have to have the knowledge to be able to know which one is going to take priority. And this is a lot of what I'm teaching you. I'm just not telling you that. Does that make sense? The way that I'm presenting this information is specifically designed to help you with that prioritization. But yeah, I wish I could tell you that you guys are all going to be fully staffed and you're going to have all the time in the world to take care of your patients and life is all rainbows and unicorns. I wish I could tell you that, but it's just not our reality. It's just not. Get involved in the conversation because nothing changes if nothing changes. But part of that too is remaining professional. The more professional you are and the more involved you are in the conversation, the more they'll hear you. Good? Questions? So this is why we have to change position frequently, even when sleeping. And that's just to allow that blood flow to recirculate back in that area so that those tissues don't die. And to do this, we're going to do it on a turning schedule or a turning clock. Every 2 hours around the clock, we're going to change position. And this is how we do it. We start out with a patient on their back. 2 hours later, we put them on their right side. 2 hours later, back on their back, and 2 hours later, left side. Back, right, back, left, back, right, back, left. Back, whoops, back, left. Back, right, back, left. Back, right, back, left. Back, right, back, left. Every 2 hours around the clock. Now, this is something that CNAs can do on their own. You can make a turning clock like this, and you can post it right over the patient's bed. So this helps me as a nurse. As a nurse, I can walk in. If it is 10:35 in the morning, okay, so where's 10? 10:35 in the morning, where should my patient be? On their back. So if I walk in the room and that patient is not on their back, I know that they're not being turned appropriately. Maybe I can help my CNA and turn this patient. I don't have to go find the CNA and say, hey, are you running behind? I know they are. I'll turn the patient for you. Good? Make sense?
Are you waking them up?
Absolutely. Absolutely. I don't ever touch anybody unless they know I'm there. It's a good way to avoid getting hit. Really. It's that simple. Remember, your patient is in a strange place surrounded by strange people in an insecure environment, and they're vulnerable when they're sleeping. You touch a sleeping patient in that condition, they're probably going to hit first and ask questions later. So what I normally do is as I approach the bed, I will touch their shoulder, their arm or their shoulder as I'm approaching the bed. Mr. Jones, it's the nurse. I'm going to turn you on your side now. And they'll probably sleep through it, but at least they know I'm there and I'm not touching them and startling them. Patients that have to be turned often, they get really good at sleeping through this. They'll wake up and grunt at you and go back to sleep and let you do what you need to do. Because there's another part of this we haven't talked about, and we're not going to talk about until next week. If our patient is immobile, if they can't move, they're not getting up and going to the bathroom. They can't move. That means they're probably incontinent. And when we have an incontinent patient, they also have to be changed every 2 hours around the clock. Well, we're turning them and we're changing them at the same time. Good. I want you to pay very close attention to the fact that there is no stomach on this list. Do not put an immobile patient on their chest. If they lack the muscle strength or the nerve innervation to lift themselves off their chest as they breathe in, if they're laying on their stomach, they can suffocate. So super important that unless the care plan specifically says to turn the patient prone, we don't put them on their stomach. Okay, good. Interesting. Every 2 hours. Yeah. So this is right here. This is midnight, 2 a.m., between 2 and 4 a.m., between 4 and 6 a.m. Good? Okay. So with COVID, right, this is a nursing principle. All nurses know this. We don't put people on their stomach. With COVID, we actually found that when we had patients on ventilators with COVID, when we put them on their stomach, their saturation levels improved. It removed the gravity, guys, gravity. It removed the restriction. So when we suspended them on their stomach, we had special beds that rotated them, it allowed their lungs to expand a little bit more. And it was really interesting because it was an ICU nurse that figured that out. And they did that for secretions. So I thought that was pretty interesting. There are some situations where your care plan may say stomach. Remember, patients always need to be in the middle of the bed, especially when they've been turned on their side. So in order to do that, we're going to scoot them toward us and then roll them away so they're in the middle of the bed. Now, how do you scoot them towards you? Well, if they can move on their own, just have them move towards you. Remember, our care plan said the patient was unable to assist with turning. So for the test, just ask them, scoot toward me. But in a clinical setting, if your patient can't scoot towards you, what do? Well, there's a couple different options here. We can move the patient in segments: legs, hips, torso, head. You can use a draw sheet. Now, a draw sheet, flat sheet underneath the patient that we use as a sling. So we just grab the edge of the draw sheet and pull it toward us. And like a sling, it's going to pull the majority of the patient's torso toward us. Draw sheets are great for this. You can also use a slide sheet. A slide sheet is super slippery, no water. Super slippery. You just put it under the patient and they move. Slide sheets are extremely expensive. They're locked up in your supervisor's office. You're going to have to sign it out. Promise your firstborn if you don't return it. They're super expensive. So this is how we prepare our patient for turning. And remember, I said you can turn somebody 3 times your own body weight if you prepare them right. So if I'm going to turn my patient onto their left side, so this is my left side. If I'm going to turn the patient onto their left side, I'm always rolling a patient away from me. So that means I'm standing on the right side of the patient. Good. If I were to turn my patient on the right side, I would be standing on the left side of the patient. So you need to know which side you're turning the patient onto to know where to stand to make this work. So you stand on the side of the bed opposite the one you're turning the patient to. So you're behind them. And you have them scoot towards you. And then, come over here so you guys can see. And then we prep their body for the turn. So the closest arm to you crosses their chest. The furthest arm goes above their head. So they look like this if I were turning them on this side. If I were turning them on the left side, they would look like this. So closest arm crosses, furthest arm up. Now we go down to the legs. Closest knee gets bent with the foot flat on the bed. The furthest knee is going to be angled out. Now, if you get a patient in this position, just like that, it doesn't take any effort at all. Hand on the shoulder, hand on the hip, and you just roll them. They're already half on their side once you get this done. You can move somebody 3 times your body weight. I used to take care of bariatric patients before bariatric surgery, before, this is way back in the 90s, before they got surgery. And I would take care of 700-800 pound patients, and I would go in and turn them by myself. It's all about the proper preparation. Okay, good? Good. Okay. All right, so when we're doing this particular skill, we're going to position them for turning. Farthest arm up, closest arm over, closest knee bent, furthest knee angled. We're going to roll them onto their side in the middle of the bed, away from us. We're going to put a pillow behind their back. We're going to put a pillow between their legs, specifically between the knees and the ankles. You don't want those bony areas rubbing together. So that pillow is going to pad those bony areas. And then the arm, the upper arm, the one that's on top, that arm is going to fall forward. And that puts a lot of pressure along the upper back and into the neck, and it can cause headaches and muscle spasms. We want that arm in a neutral position, so we put a pillow underneath that arm to get it in a neutral position. And then we look at the pillow under their head, because when we turn them, their shoulder is probably up on that pillow. So we adjust that pillow so it's just behind the head and neck. Call light is always going to go in the bottom hand. So this is a change from the video I'm going to show you. In the video, I put the call light in the top hand. Don't do that. Put the call light in the bottom hand. We don't want that cord across the patient's neck. So we're going to bring the call light and put it in the bottom hand. Good. And then we just put all the other principles we've learned together with this, and it makes a whole skill. So let's take a look.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. That did not take 8 minutes. They gave you plenty of time to do this. It takes me way longer to tell you all of the things you need to know than it does to show you the skill. Good. Questions? Am I going too fast? Let's go ahead and take our break. When we get back, we'll get into the next skill. 6. All right. Everybody ready to get started again? Okay. So if you go to page 118, do you guys remember hand and nail care? Foot care is the same thing, a little lower, but nothing to do with the nails. We don't clean them and we don't file them. We don't do anything but look. So it's an easier version of hand and nail care as long as you can get up off the floor. That's the hardest part of this. You have to be on the floor to be able to do foot care. Nothing to learn here. These are all the principles. They're all spelled out for you here. We know them all. Nothing new to learn. We're going to talk about the steps specific for this skill. This is your short version. Down here is test specific information. They give you 13 minutes to do this. You're soaking a foot, washing a foot, rinsing a foot, drying a foot, and lotioning the foot. That's it. And they're giving us 13 minutes to get that done. Do not rush this. The whole point of this skill is not to clean the foot. That's just your excuse to be there. The whole point of this is to be looking at the foot, because feet are usually covered in socks and shoes. And the problem with that is that they're covered. If the patient has any sort of a wound or ingrown toenail or anything like that, and they're always wearing socks and shoes, that whatever it is may go unnoticed and untreated. The whole purpose here is to look at the foot. So during the test, you need to say something like, I'm looking at the foot. Good. Super easy skill. Now, the problem is that we don't know if there's a wound. The whole reason we're there is to look to see if there's a wound. So for this skill, you really should wear gloves because we don't know if there's a wound. Plus feet. Right. Any questions so far? All right. You guys are mostly, this isn't a hard skill. It really isn't. The biggest problem with this is that when you're young, you're able to look at the bottom of your feet. And you can see if you have a wound or anything else. You're bendy. As you get older, you get less bendy. So your older patients may not be able to see the bottom of their feet. They're relying on you to do that. The other thing here with foot care is that we have changes of aging that we talked about, right? Nerves aren't as good as they used to be. Circulation isn't as good as it used to be. So you've got some changes that could potentially lead to an injury that the patient knows nothing about. But there's a whole nother reason that the patient may have a wound that they don't know exists. And that's what we're going to talk about today. So in order to learn how to do foot care, we have to talk a little bit about diabetes. So on page 119, at the top of the page up here, you see your care plan. It says provide foot care to one foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. For the test, we're only doing one foot. If they watch you wash, rinse, dry, and lotion one foot, they know you can do it. They don't need to see it on the other side, so one foot. It's also a live patient skill. Oops. That means that you might have your foot washed during the exam. Now, I get it. Nobody's comfortable with that. I understand. But go to your happy place and deal with it. It's a good excuse to go get a, mani-pedi before test. But somebody, if you're the patient for this, will be soaking your foot, washing your foot, rinsing your foot, and lotioning your foot. But you probably are not taking a clean pair of socks with you to the test. That's why the care plan says that the sock and shoe should be replaced at the end of the skill. It's telling you for the test, there are no clean socks. Put whatever they wore back on. Good. Same skill. Biggest difference is with hand and nail care, we cleaned under the nails and we filed the rough edges. We're not doing that for foot care, but we are looking. That's the big change here. We are looking. So for the test, you have to say something about, I'm looking at the foot. In order to understand why this is important, let's talk a little bit about diabetes. A lot of your patients are going to have diabetes. It is a rapidly increasing condition in America. And it's so funny because a lot of people will say, I've never had diabetes before. I'm 67 years old and all of a sudden now I have diabetes. And they think it has something to do with their eating habits over the last year or so. And it actually doesn't. The reason that a lot of older people develop diabetes that they never had before actually started when they were 3. So let me take you through why this happens. So in your body, you have cells. Your cells run on glucose. It's what they need. That's their fuel. That's what fuels cells. Now, glucose we take in the form of carbs. So you eat carbs, they break down into sugar. That sugar goes into the cells, and the cells are happy. Make sense? Okay, cells run on sugar. Now, what's an example of a carbohydrate? Bread, rice, pasta, potatoes, flour, anything made with flour, sugar, anything made with sugar, and that stuff hides in a lot of foods. But we call it the rule of white. If something is white, look at it, or made with white stuff, look at it with a critical eye because it could be carbs. So good. Cells need sugar. The sugar comes in the form of carbohydrates, which is broken down by the body. All right. So in a perfect world, we have a patient who ate carbs, broke down into sugar. That sugar went into the bloodstream, blood sugar in the bloodstream. Well, that sugar in the bloodstream can't get into the cells all by itself. It needs a key to open those cells. Now, that key is actually produced in the body, in your pancreas. The key is a hormone called insulin. Now, wait a minute. We talked about hormones earlier today, and what did I say happens as we age to our hormone levels? Oh, so this might be a contributing factor as to why somebody in their 60s all of a sudden developed diabetes. Hormone production decreased, and insulin is a hormone. So that's going to play a part in this. But there's a bigger issue here. So your pancreas produces keys when your body has sugar in the blood. And those keys open the door and allows the sugar molecules to enter the cell. And then the cell can use that sugar for fuel. Okay, good. So sugar requires insulin to get into the cells. So the real problem here is that if our insulin has decreased or has gone away and we eat carbs, They break down into sugar. The sugar goes into the bloodstream, but there's nothing to open the doors. So the sugar stays in the bloodstream, but your cells are starving, dying. Hey, hello, I need some fuel. And if you've ever known a diabetic, they crave sweets. The reason they crave sweets is because their cells are yelling at them, hello, I need fuel. So the brain says, oh, let's get you some. Triggers a craving for sweets. The patient eats the sweets, but it doesn't help because that sugar is not getting where it needs to be in the cells. Interesting though, the cells actually have a back door. It's smaller, not as efficient, but if the patient eats protein with the carbs, that protein will enter the cell through the back door and it will reduce that craving because now the cells aren't starving, they've been fed. Protein isn't as good of a fuel, but it will help. So if you've got a diabetic patient who has a bag of M&Ms hidden under their pillow, and most of them do, if you can talk them into eating some protein with those carbs, like an apple and cheese, graham crackers and peanut butter, a half of a tuna sandwich, if you get them to pair carbs and protein, it helps cut down on these cravings. And the cells don't die because they are receiving fuel. Good? Good? Okay. There's a really good way of balancing this, guys. You really should take in half as much protein for every carb that you're eating. So if you're eating, let's say you go to McDonald's and get a medium fry and it's like 40 grams of carbs, that means that you need to eat about 20 grams of chicken to offset that. That's a lot of chicken. That's a lot of protein. So if you start looking at that ratio, whatever you're going to eat in carbs, you need to eat half as much in protein. So 2-to-1 ratio. You will start decreasing your carbs naturally because you can't possibly eat that much protein. It's just instead of we are driven by our psychology. And a lot of times if you tell somebody, hey, cut down on carbs, it's hard to do. Carbs are good. We like carbs. They taste awesome. It's hard to do. So no, you don't have to cut down on your carbs. You just have to eat half as much protein as you take in carbs. Well, that's a whole lot. So you naturally start to decrease without feeling like you're sacrificing. Good? Make sense? Pretty cool, right? All right. So no insulin means your cells are hungry. That's going to trigger cravings. So if we have all of this sugar in the bloodstream that can't get into the cells, what's happening there? Where does it go? What does it do? Why should we care? Well, sugar is a crystal. If you've ever left a cake or a cupcake out on the counter for a couple of days, the frosting actually separates. It becomes oil and then kind of like grainy sugar. That's sugar. That's the same stuff in your bloodstream. Literally, it is sugar crystals in your bloodstream. And this is what crystals look like, guys. That is what crystals look like. They're sharp. They're jagged. And they are floating in your bloodstream. That can't be good for anybody. And what will happen over time is those crystals, because of gravity on planet Earth, they're heavy. They get pulled downward. Crystals, heavy, get pulled down because of gravity. So that means that these crystals are going to line the inside of your blood vessels. They just accumulate there. But they're going to do it in bigger concentrations at the lowest points of your upper body, which are your hands and the lowest points of your lower body, which are your hand and nail care, foot care. That's why we do these two skills. Because diabetic effects are going to be amplified in the hands and the feet. And that's why we have to do hand and nail care and foot care. Good? Questions? All right, let me show you what this looks like in the artery. So when you're born, you get arteries that look like this. And that is a nice, pretty artery. I wish my arteries looked like that. They don't. But this is what it looks like when you're born. These arteries can expand, they can contract, lots of room for blood, no worries. But they don't stay like this. And that's because our American diet is not good for arteries. It's just not. So let me explain to you what happens. So 3-year-old gets up, 5:30 in the morning. Mom says, way too early. Gives the kid a Pop-Tart, sits him in front of the TV, and mom kind of naps on and off on the couch until a more decent time. Well, that Pop-Tart is carbs. They break down into sugar, and the pancreas has to produce insulin for that sugar to go into the cells. We learned this. Mom finally gets up off the couch around 7 and gives the kids some cereal, a proper breakfast. But kids aren't eating all bran, are they? What do kids eat? Cocoa Puffs, Frosted Flakes, Fruity Pebbles, one of my favorites, Captain Crunch, all of the good stuff, right? But they are pure carbohydrates. So carbohydrates go in, they break down into sugar, the pancreas has to produce insulin. Mid-morning snack. Mom's good mom gives the kid fruit. Fruit is still carbohydrates. They break down into sugar. The pancreas has to produce insulin to get the sugar in the cells. Lunchtime, toddler diet, chicken nuggets and mac and cheese. We have a little bit of protein in there, but mostly it's carbs, especially if we serve it with ketchup on the side, which we do. Right? So we have carbohydrates that break down into sugar and makes the pancreas produce insulin to get that sugar into the cells. Afternoon snack, a little Debbie something, snack cake of some sort, which are carbohydrates breaking down into sugar that requires insulin to get into the cells. Dinner, buttered spaghetti, carbohydrates, breaks down into sugar, requires insulin to get into the cells. And then, of course, we have to have dessert before we go to bed. So a couple of cookies are carbohydrates, which require insulin to get into the cells. So do you see how much your pancreas has worked on this one day? And that is a normal diet. You keep that up for most of your life. Our diet is very carbohydrate heavy, which means that our pancreas has to work overtime all the time. And by the time we get into our 60s, the pancreas just says, done. I'm out, dude. You overworked me. I'm off the clock. So we have somebody in their 60s. It's like, I never had diabetes before. Well, you overuse your pancreas. So if you guys want to avoid that in your future, you need to think about how much you're asking your pancreas to do. Make sense? Good? Okay. Cyan, do we need to wear a mask during foot care? Masks do not help with odor. If you're doing this for odor, masks do not help with odor. They aren't going to cut odor. I don't know. Do you have a respiratory infection? If you do, wear a mask. Does the patient have a respiratory infection? If you do, wear a mask. But it's not going to help with odor. That's not a thing. Okay. So over time, as we eat this American diet, right, all of this stuff starts to build up in our arteries. And our arteries start to look a little more like this. Now, if you look, it is smaller in diameter. Not much, but it is smaller in diameter. And we're getting a little gunk buildup. So this is like in our 20s. You're still healthy. You're still good. But we're starting to see a little change. Now, by the time we get into our 40s, we're on high blood pressure medication because we don't have as much room in our arteries for blood, which means there's more pressure in there. High blood pressure. And it's because our arteries are getting clogged up. Now, you add diabetes in there, you throw these crystals in the mix that are going to capture everything that floats by. All of the cholesterol, which looks like pizza cheese in your, legitimately looks like pizza cheese in your arteries. As it floats by, it's going to get all tangled up in those crystals. Those crystals are going to shred platelets as they float by. They're going to destroy white blood cells. So you end up with a big, gloopy mess inside your arteries. And that keeps blood from flowing very well in those arteries. Now, something you need to know about blood is anytime it slows down or stops, it clots. So what is our patient at risk for? Blood clots. Absolutely. Good?
What would be the procedure to fix like clogged arteries?
You can't fix that.
You can't fix that?
Mm-mm. No. So let me give you a visual. Tree outside. You've got a trunk. You got branches. And then it goes down smaller and smaller and smaller to twigs, right? It's exactly what's happening in your body. Your artery is the trunk. Arterioles are the branches, and they get smaller and smaller and smaller, and those become capillaries. So if we've got all of this gunk on the inside of our arteries and you try to push it, the artery gets smaller and smaller and smaller and smaller. This isn't going to fit. So all you're going to do is make a bigger clog in a concentrated area. You can't get rid of that. There's no do-over. Take care of your arteries. You only get one set. And you got to make it last your entire life. This is where exercise can help, though. Because with exercise, particularly cardio exercise, you get your heart beating fast. That increases the pressure in the arteries, but it also dilates the arteries. So now we can get whatever's loose, we can kind of wash away with that improved blood flow. So if you want to avoid that, 15 minutes of cardio every day and watch your carbs. Avoid that. By the time you get into your 50s, it's too late. The ship has sailed. Okay?
When they clean off like your neck and this area, what's that called?
So what they do, endarterectomy is the term for it. What they do is they actually cut this artery open, your carotid artery. They cut it open it up like the cargo bay on a shuttle, and they suck out the goop, and then they sew it back together. But that just works on that one artery that feeds your brain. It doesn't do anything about all the other arteries in your body.
What is that scope thing they put in there?
So that's going to be a heart cath, and that's a camera. We go up through the arteries to look at the blood vessels to see how goopy they are. Yeah. Now, we can't put a stent in. A stent is like, take a piece of paper, roll it up super tight. As tight as we can get it. And then we slide it into an artery, and we let it expand. And then whatever gunk is on the inside of the artery gets pushed up. So it gives us a bigger tunnel. That's what a stent is.
So what's the point in doing the scope if they can't do anything?
All the scope is going to do is look. It's just looking. Now, while they've got the scope in there, they might put a stent in just to push the gunk, give us a wider opening. But the scope itself doesn't really do a whole lot, but tell us what we're dealing with. Sometimes they use a balloon, same thing, balloon. They just puff it up with, air or sterile water, and it pushes the gunk. You remember, this is goopy. So we can push that gunk and give us a little bit bigger tunnel for our blood. But again, there's no fix. We're just treating it, no fix.
Why can't they just get it out?
Do you know how many arteries you have in your body?
So you can't, because you would have to get the whole thing.
Yeah.
Because it's connecting completely.
It's not just in one place in your, it's your entire body. Yeah. The equivalent, okay, a kitchen sponge, right? You know how many holes are in a kitchen sponge? Take a needle and try to pull out water from every one of those holes. You really couldn't. There's just too many, and they're all interconnected. Well, that's your arteries. But if you ever invent one, you'll make a fortune. If you figure out a solution for this, you will have more money than all of the billionaires combined. Because this is a big problem. This is what kills most Americans. Good? Avoid it. 15 minutes of cardio a day, guys. But it gets worse. How can it be any worse than that? It gets worse. So it's not just arteries we have to be concerned about when we have diabetes. This sugar that's in the bloodstream circulating, and it's all it's doing is circulating because it can't get into the cells. Round and round, that's why we call it high blood sugar. Got a lot of sugar in the blood because it can't go in the cells. Round and round and round. Now, the problem with blood sugar is you can't really excrete it. You can't pee it out. It's not like vitamins. You take in too much vitamin B, you're going to pee out whatever you don't need, whatever you don't use. It doesn't work like that. When you got excess sugar in the system, it is there to stay. Now, what we do when we have excess sugar is we pack it up in a little packing box and we shove it in a storage unit called a fat cell. That's what your fat cells do. They store excess sugar for later, just in case you need it. But if you ever go look at Granny's storage unit, all of the stuff in there, so outdated. Nobody would ever use any of it. It's obsolete. So fat cells that have been around for a long time, the sugar that's in there can't really use. It's old. It's icky. Nobody wants it. So this is why it's hard to lose weight, because you can't do much with the sugar in that fat cell if it's been there for a long time. Good? Make sense? You got the visual? All right. So what happens when we run out of fat cells to store the sugar in? It just stays in the bloodstream. Round and round and round it goes. Over time, that's why we get diabetes, high blood sugar. Over time, that sugar will actually go beyond the arteries and it starts to affect our nerves. Now, if you've ever been up north in a blizzard, when you get ice on the lines, you can actually get brownouts. So there's power out there at the road, but the line that comes from the road to our house is all covered in ice and the signal can't get through. Make sense? It's a coating that prevents signal transfer. That is what happens inside our body on our nerves. So we have a coating on the nerves that prevents signal transfer. And because of gravity, we're going to see that in the hands and the feet more often. So when we have a patient with long-term diabetes, they can have an injury and not even know it's there because the foot knows there's a problem, but it can't get that message to the brain because the wire, the nerve that goes from the foot to the brain, covered in sugar, nothing's getting through. Gabrielle, I passed my CNA test. Thank you for all your videos in your class. It was a big help. Oh, congratulations. I love to see those. Congratulations. So this is a problem. And let me give you a story with this. Many, many years ago, I was working as an agency nurse. Now, an agency nurse is a substitute nurse. I don't work for the facility. But when they don't have enough nurses, they call an agency and they send in a substitute, like a substitute teacher at school. So I go in, not my patients, not my facility, but I'm going to be the nurse for the day. I don't know these people. And I walk in the patient's room and he had the big light off. He had one small light over his bed, but the big light was off. And as I walk in, I got to do an assessment. So I flip the light on. He starts screaming right away, turn it off, turn it off, turn the light off. Okay. So I turned the light off, walked up to the bed, and I said, hi, my name's Patty. I'm your nurse today. I've got your pills here, but I'd like to do a little assessment and kind of get to know you a little. And is there a reason why we don't want the light on? What's going on? Do you have a headache? And what's going on? He's like, no, no, no. I've got diabetic retinopathy and the bright light really hurts my eyes. Okay, cool. So as I'm standing there and we're having a conversation, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive. Now, I know that this guy's probably got a wound brewing somewhere. So I get permission. I need to take a look. He says, do what you got to do. Now, this guy was in his 50s, very gruff, very not, I wouldn't call him pleasant. Okay. So I look at all the usual suspects. I look at the tips of the ears, the back of the head, his shoulders, his lower back, his buttocks, back of the legs. I get down to his feet and he's got those slipper socks on, you know, the kind with the little dots on the bottom to keep you from slipping. And I say, Henry, I need to take your socks off so I can look at your feet. He immediately barks, no, leave my feet alone. Okay, well, there's my red flag. If he told me no, what did he tell the CNAs? No, and nobody reported this. Nobody. So I sweet talked him. You can always get further with patients by being nice than being mean. So I turn up the charm and I get him to allow me to take his socks off. Right sock came off, no problem. Left sock stuck to the bottom of his foot. So I go get a big basin of warm salt water. We call it saline. Put the whole foot, sock and all, in the basin. Go take care of somebody else. Come back, get my gloves on. And I tried to take the sock off and it stuck to the bottom of his foot. So I had to get a little pressure. And when I gave a little bit of pressure, something flew past my head. That's not a good sign. So now I'm counting toes. 1, 2, 3, 4, 5. They're all there. What went flying past my head? This. This is one of those flat metal thumbtacks. It was painted white. It blended into the tread on his socks because remember, he kept the overhead light off. Nobody saw it. Now, you might be asking, how in the world can this guy have a thumbtack in the bottom of his foot and not know it's there? That's why. Told you the guy had diabetic retinopathy. He had diabetes. He had a thumbtack in the bottom of his foot, did not know about it. He could not feel it. So the wound was about this big around, hard, dead tissue. What did I tell you about dead? Yeah, we're not Frankenstein. I know this guy is going to be in for a very rough road. So I called the doctor, called the family, called the wound care specialist, did my wound care, took my pictures, documented everything. I go home, not my facility. About 9 months later, maybe a little longer, I'm not sure the time frame, I get sent back to that facility. Now, originally, when I was there, I was on the rehab side. That's where he was. Now, today, I'm on the long-term care side. And I'm looking at my assignment sheet, and there's his name. So I go in. Hey, Henry, I'm Patty. I'm the nurse that found the wound on your foot a couple months ago. Just want to see how you're doing. I'm back here today. He pulls the sheet over, and he had to have a below-the-knee amputation. He lost his leg. Lost his leg. Now, if you remember, I told you he was in his 50s. This is way too young to live the rest of your life in a nursing home. You think he was grumpy before? Now, the really sad part about this for me, the tragic part about this is that it was 100% preventable. Because if that guy had had shoes on when he was walking, where would the thumbtack be? We don't amputate shoes. When you have a patient that is walking, they should have shoes on their feet, whether they have diabetes or not, but especially if they have diabetes. Because if they have any nerve impairment, any injury they get, they may not be aware of. If you're the CNA caring for patients and they say, no, I don't want foot care, you need to report it because there's a foot that's not being looked at, not by the patient, not by anybody. If they had caught this wound earlier, it may have been a different ending. This was tragic. Would you guys want to live in a nursing home? But he wasn't able to care for himself. So we've got to get better at what we do to have better outcomes for the patient. Good?
If a patient is epileptic and they have a seizure, and then after they're complaining of they can't feel their fingertips or their toes, is that what happens?
No, they can't feel their fingertips or their toes because of nerves, yes. You're on the right track, but wrong train. This, they can't feel the nerves because they're coated. Like rock candy, right? Coated. Can't see, nothing's going to get through. With epilepsy, it's a lightning storm in the brain. That's what epilepsy is. It's all the electrical signals in the brain firing off at one time. So it's just chaos up there. And because of that, the brain can't work. It just kind of goes offline. Well, remember, the brain is attached to all of the nerves in your body. So when the patient regains consciousness, sometimes the nerves further away from the brain just haven't really come online yet. Okay, we got to do a system check. Good. Does that kind of make sense? If you have a patient that's having a seizure, time the seizure, let the nurse know how long the seizure lasted. Do not leave a patient having a seizure. Make sure they don't get injured and send somebody to go get the nurse. But don't leave somebody who's having a seizure. Try to keep track of how long the seizure is taking so that when the nurse gets there, you got that information.
So whenever we are walking a patient, even if it's just a wheelchair, he has to have shoes on?
The rule is so I want you to turn around real quick. And do you see that shoe rules banner behind you? Can you read the very first top line?
If a patient's feet hit the floor, we talk about their shoes.
Right. So that's our rule. If their feet are hitting the floor, we got to talk about the shoes. I would prefer that they're wearing them. If there is a reason they can't wear them, we're going to at least talk about it. And I would definitely let the nurse know, hey, that patient is not wearing shoes because there is a risk there, a significant risk. Good? So we're going to cover that a little later. All right, so does everybody understand a little bit about diabetes? right? So if the patient's feet hit the floor, we talk about their shoes. For the test, you're going to put the shoe on the foot after you wash it. You're not going to leave it to the side. You're going to physically put a shoe on the foot. For the written test, the right answer for any question that has to do with the patient's feet hitting the floor, they need shoes. But a question comes up all the time. Well, what if the patient doesn't have shoes? What if they just don't have them there? Well, in that case, who would you tell? The nurse. Yeah, remember, nurses exist to solve problems. Give me a problem. I like to solve them. If this patient is homeless and doesn't have shoes, we have social workers that have gift cards that can go get the patient a pair of shoes. If the patient came from a facility, a nursing home, an assisted living facility, we can call up the facility and say, hey, we need Henry's shoes. Somebody bring them. If the patient came from home and has a family, we call up the family, say, hey, we need shoes. We can solve that problem in some way. Now, if the patient just flat out refuses to wear shoes, who should know? Every observation, no matter how small, gets reported to the nurse. Good? Okay. We're going to get to the rest of these later. So for the test, we're actually going to put the patient's shoe on their foot and tie it appropriately. Slipper socks are not enough to protect against injury. You need to understand this. If this patient had shoes on, there wouldn't have been a story to tell you. Shoes are important. But unfortunately, in healthcare, we get stuck on these things. We think, well, slipper socks, at least they're not slipping. And we stop there. That doesn't protect your patient. Let me ask you a question. Would you be comfortable with a small child walking barefoot in a hospital? Why? Why? There could be needles on the floor. Why else? Pathogens, sure. If you would not feel comfortable letting a small child walk barefoot on the floor of a hospital, why are we perfectly okay with an adult doing it? Those same two dangers exist. Good? Did I rearrange your thinking a little there? How many of you guys have ever been a patient at a hospital? When you're a patient in the hospital, they put a gown on you and give you those slipper socks. And you probably walked all over the place in those slipper socks. You definitely walked to the bathroom and back. Do you know what pathogens are on your socks when you walk to the bathroom and back? And you didn't take those socks off when you got back into bed, did you? What crawled into bed with you? All those pathogens, yep. And if you had an incision, those pathogens, as you move around in bed, will get into that incision and cause a surgical site infection. Gross. So slipper socks, not enough. Good? Ugh. Down the road, we'll call it Hospital ABC, has a Subway in their lobby. And I have seen patients in the Subway, in the lobby, with patient gown on and slipper socks. Do you know what they had to walk through to get there? Slipper socks, not enough. All right, so this skill is super easy. We soak the foot, we wash the foot, we rinse the foot, we lotion the, or we dry the foot, we lotion the foot. That's it. But what's our most important step? Looking. That's right, looking at the foot. So during the test, you have to say something like, I'm looking at the foot. Good? Questions? Here's our care plan at the top of page 119. Provide foot care to 1 foot using soap and water. Resident is sitting in a chair and their sock and shoes should be replaced at the end of the skill. All right, let me go ahead and show you this one.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. You want to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands. And apply lotion to all surfaces except between the toes. So I'm going to lift your foot, and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There you go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. So dump it, rinse it, dump that out, set it down. We would spray it if we needed to. Paper towel to pick it up, paper towel to dry the inside, throw that away, paper towel to dry the outside, throw that away, and then one more for the drawer. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, so no lotion between the toes. Lotion holds in moisture, and we don't want moisture between the toes because it's already warm and dark there. And when you have moisture being held in that area between the toes, it predisposes the patient to athlete's foot, a fungal infection. So especially because it's in sock and shoe and a humid environment. So no lotion between the toes, but lotion everywhere else. And then wipe the lotion off. Remember, all of our washing rules apply. We get water, we check it, they check it. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get your surface wet. That's why we have a barrier there. All of those same rules that we've seen before apply. Any questions on that one? No? To me, that's probably the worst skill to get. By the way, the one that you dread is the one you will get. It always happens that way. I don't know why, but it's like the law of attraction or something. I don't know. I would not want that skill because I can't get up off the floor anymore. So I would not want that skill. But, you know, a lot of people dread things like denture care. To me, denture care is super easy. You clean the dentures and then you clean the mouth they came out of. You know, we brush our teeth all the time, so we know that skill. So to me, this is the worst skill.
At a facility, can you sit on a towel when you're doing that?
Sure. Barrier towel. Some facilities are now, and I love this idea. Some facilities are now investing in super low rolling chairs, you know, like they have at the pedicure places. And man, that makes life so much easier. So, you know, hopefully you work at a good facility that has that. If not, ask for one. Doesn't hurt to ask. All right. So now we're going to move on to mouth care. So this is on page 92. You guys all know how to do this. Question. Miss Patty, the basin we use for the bed bath is the same we use for the foot care. Yes, absolutely. One basin to rule them all. So the wash basin is just going to be used for washing, whether it's foot care or washing the body or whatever. If you're washing a particularly funky foot, you might want to put some soap in the basin when you're cleaning it. But for the test, it's another testing student. It's one of you guys. So I would imagine the basin's probably not going to be too terribly funky. But we don't want to, okay? Okay. We don't want to get extra basins. So this comes up a lot. Well, why can't I just throw that basin away and get a new one next time I need one? Anybody here ever get a bill from a hospital? Yeah, you got to pay for that care, right? It doesn't come free. And everything that they use, you're going to get a bill for. everything. And those basins are, you know, somewhere between $30 and $50 a piece. They don't go to the Dollar Tree and get the basins. They're expensive. So if you're just grabbing supplies like it's all free, that patient is going to get a bill. And those things are going to be on the bill. So you can ask for an itemized bill, by the way, and you can dispute things. So don't get supplies unnecessarily. Clean them. All right. So let's go to page 92 and learn mouth care. Again, down the side, you see all the principles. They're all spelled out here. Nothing new to learn. Nothing new to learn. This is the short form, kind of gives you your basic steps. Down here is test-specific information. They are giving you 12 minutes to brush somebody's teeth. And it's not timed as far, you don't have to brush for 2 minutes. Just brush, top, bottom, front, back, tongue. Doesn't have to be 2 minutes. And they're giving you 12 minutes to get all that done. I mean, that's way more time than you need. Way more. But if you look at the next space, who's going to be a patient for this? We are. That's right. So somebody may be brushing your teeth for the state exam. How many of you are excited over that? How many of you cannot wait to have somebody brush your teeth? Yeah. Nobody wants to be a patient for this skill. Nobody. I get it. Do you know who else doesn't want to be a patient for this skill? The patient. Out there in clinical setting, they're not just sitting around waiting for somebody to get into their mouth. If they can brush their own teeth, they are going to brush their own teeth. They do not want you in their mouth if they can do it themselves. So the only people that we're brushing teeth on are those that cannot brush their own. We get independent at this about 4 years old. And from that point, nobody gets to brush our teeth. But when you're the patient for this, for the test, be a patient. Just be cooperative. Let somebody brush your teeth. Go to your happy place. I get it. Nobody wants to be a patient for this, but it is a tested skill and we need patience for the demonstration. Okay. So, yes. So if you have braces on, you want to let them know during the test when they ask you, do you have any conditions that would keep you from being a patient for any of these skills? You want to say, I've got braces. They're not going to pick you for mouth care. Yeah, unless there's absolutely nobody else. Like if you just had dental surgery and you just had your teeth pulled and you're allergic to toothpaste or, you know, unless there's absolutely nobody else, you'll get a get out of mouth care free pass. Good. Questions? There's not much to teach you here, guys. Not much to teach you. The big issue with this skill is right here. It's going to be a live patient, but where are they going to be? In bed. Now that does add a little complexity to this. And that's because normally when you brush teeth, where are you? Yeah, you're standing over the sink. So you're kind of leaning forward over the sink. This person's in bed. So, and not only are they in bed, they're laying in bed. So what do you think a big safety step is going to be for this? Yeah, get them sitting up. Absolutely, get them sitting up. That's going to be a really big safety step for this. Other than that, this is a really, really easy skill to do. If you look at the top, page 93, wow, that's really washed out. Yeah. So if you look on the top of page 93, you'll see our care plan. It says, a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide mouth care to themselves. Remember, if they can, they will. This one can't. Did I tell you about these questions? Every lesson has a gray box that has questions in it. These will help you learn whether you know what you need to know from that skill. So these are kind of important points. You should always look at these after we go over the skill and make sure you can answer them. I've got those in every lesson for you. All right, so your patient has to be sitting fully upright. So not a little bit, they've got to be sitting upright. Remember that semi-reclined is not a safe position for mouth care. We need the head of the bed to go all the way up until it stops. But this is a problem, and this trips students up all the time. So I want to get into this a little bit. Remember that we've done our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do mouth care. Is that okay? I've closed the curtain and I've washed my hands, right? I've done all of the things. I got to put the head of the bed up. So I got to figure out when in all of that process I should be putting the head of the bed up. Is that bed controller clean? No. So do I want to touch it after I wash my hands? Okay, but there's a problem here. If I touch it before I wash my hands, which is ideal, when we get the patient sitting up, the pillow that's behind their head is going to force their head forward a little bit. This is not a safe position for mouth care. I've got to lean them forward and put that pillow behind their back, or take the pillow all the way off the bed. Either way, can I touch that patient before I wash my hands? All right, so we got to put the head of the bed up and we have to adjust the pillow. One of them I can't do until after I've washed my hands. Do you see where there's a problem here? So here's your solution. You do your whole opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do mouth care. Is that okay? Close curtain, wash hands. And I'm going to grab a paper towel. And I'm going to use a paper towel between my finger and the bed controller to get the head of the bed up. And now I can adjust the pillow. Good? Good. All right, I'm going to show you a video on this. I don't do that in the video. In the video, I put the head of the bed up and adjust the pillow before I wash my hands. Remember, you cannot touch the patient until you have clean hands. I just retaped all of the videos, but I haven't had a chance to edit them yet. So we will have new videos for this coming up, but probably not before you test. So if you look at your step-by-step instructions here, it tells you, knock, greet resident, identify by name, introduce yourself, explain procedure, get consent, close the privacy curtain, wash hands, and then use a paper towel to raise the bed to a full sitting position and adjust the pillow. So this gives you your step-by-step directions, the right way to do it. Good? Good. Okay. Other than that, not much to teach you. Put a towel on them. You know, you got to protect their clothing. They're not standing over a sink. Wet the toothbrush before put toothpaste on it, just like wetting hands before we or put soap on them. We're going to brush whatever they got, top, bottom, front, back, tongue. Nobody cares how long it takes. Nobody cares what order you do it in. Just brush the top, the bottom, the front, the back, and the tongue. That's it. It's not overly complicated. Let them rinse as often as they need to. But here's a tip. When you are brushing your teeth over the sink, you probably use quite a bit of toothpaste because you're over the sink. When you're brushing somebody else's teeth and they're in bed, don't use that much toothpaste because they will be rinsing till like the cows come home. A little pea-size amount is all you need. So don't do one of these big stripy things. Little pea-size amount is all you need. Let them rinse as much as they need to, and then dry their mouth. Don't leave them a wet, drippy mess. Now, we taped these videos about 6 weeks ago, and it took us about 2 weeks to tape all of these videos. We do every single video at least 5 times from 5 different camera angles, and I got to edit all that and put it together. But one of the things we did this time is the wrong things, right? Bad steps, things you should not do. And this was the one that we all died laughing at. We left him in bed, dripping, toothpaste everywhere, and he's trying so hard not to crack up, because talk about uncomfortable. Don't leave your patient. Don't get so focused on your steps that you forget there's a patient under there. Do you know how hard it was for me to leave somebody sitting like that? Pay attention to how your patient looks. If you remember me telling you on day 1 that the evaluators are paying attention to the patient, you guys remember me saying that? You got to remember that with this skill. You've got to pay attention to the patient, because the danger here is you're going to get so wrapped up in your steps, you'll forget to look. You will. You'll forget to look, and you'll leave them a drippy, wet mess. All right, so nothing here to learn. We're going to make sure the patient's sitting up, protect their clothing, wet the toothbrush, apply the toothpaste, brush all surfaces, let them rinse and spit, and leave them dry. That's it. That's all we got to, all we have to know to do this. So let's show you the video for this one.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. Look how thrilled he was to have his teeth brushed. All right, any questions on mouth care? Any questions on mouth care? It's a pretty easy skill, honestly. It's one that you all are familiar with. Just remember to put the head of the bed all the way up. All the way. You can do it before you wash your hands, but don't touch the pillow, or you can get a paper towel and do it after you wash your hands, which is probably a better way. All right, remember, you're not going to brush everybody's teeth. If they can brush their own, they will. You may have to set it up for them, you know, like get their toothbrush and get the cup of water and all that. You may have to clean up, but we're not going to brush everybody's teeth. Let me tell you a story about this real quick. I was a hospice nurse for about 6 or 7 years, and this was one of the worst cases that I had. And this is a little graphic. I'll try to make it a little less graphic. But I want to show you just how important mouth care is. We had a patient, we were called in as a consult. The patient had a brain abscess, and it was terminal. It was going to kill them. So we were called in, and this patient had a huge hole in the side of their face, up through their sinus cavity and into their brain. And this occurred because nobody brushed her teeth. She was a dementia patient, and she had pocketed food way up here. Nobody brushed her teeth. Nobody knew that there was pocketed food way up here that decayed and ate into her gum. And when it ate into her gum, there's no space between your gum and your sinus. Your sinus leads directly to your brain. And they could smell an odor, but the people that were taking care of her did not care for her properly. And the first sign, she stopped eating. The first sign that something was wrong is she had a sore on the outside of her cheek, looked like a pimple. And nobody did anything about it. And the sore grew. And then it opened. And by the time it opened, the abscess had already gone into her brain. So the external manifestation, the sign that we could see, showed up after all the damage was done. Because your cheek is pretty thick. And that to me was just criminal. How can you not brush somebody's teeth and cause something like that to happen? It's just awful. We got to do better than that. Now, on the other end of the spectrum, I mean, dental hygiene is important. We can all agree. Anybody see the headlines today? A CNA at a hospital was videotaped. Did you see this? Videotaped flossing her own teeth at the bedside of a patient on a ventilator. Yeah. So, yes, dental hygiene is important, and yours is too, but please don't do it over a patient. I mean, that just, what was going through her mind? Yeah, do a search on it. Yes. CNA flossing teeth. It'll show up. Crazy. Crazy.
I've practiced this on my mom,
Mm-hmm.
and she told me to do this to like be able to will I have to do that to
Depends on your patient. It really does. Some patients will be able to open wide and you'll be able to reach everything. Some patients you may have to, you may have to just, and their jaw needs to be somewhat closed so that you have slack to be able to move the cheek out of the way to get in the back. It really depends on the patient. And just make sure the jaw is somewhat closed. Because when your jaw is open, and you can try this on yourself, but when your jaw is open, the cheek is really stiff. You can't really pull it to the side. So you need that jaw closed enough to be able to retract it. Okay. Good question. All right. Oh, another question. Can I refuse to be a patient in the test when we do mouth care? No. No. You can. I mean, yeah, you can, but you're going to make those evaluators super grumpy. Do you want a grumpy evaluator? No. No. Just let somebody brush your teeth. I mean, unless you have a reason, like if you've got stitches or an abscess or braces or something like that, yes, but just try not to be difficult. You'll make those evaluators grumpy. You don't want them grumpy. All right, and the last skill that we're going to learn today, you will have practice time in class today, probably about a half hour of practice time in class today, and you'll be able to practice some of the things that we've learned. Remember, you have practice kits with you that has everything that we need. On Monday, we'll have about 45 minutes of practice. Next Wednesday, we'll have about an hour to an hour and a half of practice. So as we get into the program, I talk less and you're able to practice more. Good? Page 54 is our last skill here. Oh, no, we don't have, I'm sorry, back up. Today, we don't have practice time. I've got to give you the registration packets. So I knew, usually it's week 3. How am I so far ahead? I'm not. All right. Page 54 is all about respirations. Nothing to learn here. We know every single principle we need to do this skill. So what we need to focus on are the steps specific to respirations. So let's get into that. Care plan at the top, page 55, tells us patient will be lying in bed for skill. Count the patient's respirations for 1 full minute and record your readings. How long are we counting for? 1 full minute. Let me go back here. How long do they give us to do this skill? Yeah, they give you way more time than you need. This is the most common skill on the state exam. This shows up on more care plans than any other skill. So chances are we'll probably get this skill. Okay. Thankfully, it's a super easy one. All you're doing is counting somebody's breathing, but there's a few problems here. You don't want to tell somebody you're counting their breathing. I'm counting your breathing. Ready, go. Right? You will either stop breathing or you're going to start breathing fast because you're anxious. You don't tell someone you're counting their breathing. What we want to say is, I'm taking your vital signs. But the other part of this, not just tell, but show. We don't want to just stand over somebody and stare at their chest. Do you know how creepy that is? If you just stand there and stare at somebody's chest, super creepy. We don't do that. We're going to hold their wrist like we're taking their pulse. From the outside, this looks like we're taking a pulse, but we're actually watching the chest. I'm not finding the pulse. I'm not counting here. I'm watching the chest rise and fall and counting that instead. And there is a trick you can do with this skill to make it so much easier to count. I'm going to show you that. In and out counts as 1 cycle. So, doesn't matter whether you count on the inhale or the plateau or the exhale, the whole thing counts as one. So it doesn't matter where you're counting it. Does that make sense? Okay. So if you want to count when they, that's fine. If you want to do the number when they're, if you want to count on the exhale, doesn't matter. The whole thing counts as one. Normal is between 12 and 20 breaths a minute. Our care plan tells us we're going to count for 1 full minute. So we should get between 12 and 20. What if we don't get between 12 and 20? What do? Tell the nurse. Now, if the care plan doesn't say 1 full minute, we can do that whole 15 seconds and multiply it by 4 thing, like we did with pulse. But for the test, we're going to count for 1 full minute. 12 to 20 is our normal value. Page 48 tells you a little bit about documentation. We talked about this already. Be accurate, be brief, be complete, limit the use of I statements. But you may want to read that page. And then your step-by-step instructions are here. So because I don't have a bed here, this skill is going to be a live patient like you laying in a bed, but I don't have a bed right now. I'm working on that. I'm trying to figure some things out. But because I don't have a bed here, I'm going to show you the video. Now, on the video, you can actually see him breathing. And the reason you can see him breathing, and we're all going to count together, is because I put something on his chest or his abdomen. I'm going to put an alcohol pad there. And that's because your eyes are trained to look at things that are moving. This is psychology. Your eyes will be drawn to movement. So when you put an alcohol pad on the tummy, it's a contrasting color, and your brain will actually be able to see the respirations easier. You don't have to use an alcohol pad for the test, but man, it makes it so much easier to count. And they let you do it. So you might as well use the cheat that they're letting you use. Okay.
If you do use an alcohol pad, you have to like say something like, I'm going to place this on your stomach and just do it.
Here's the thing about alcohol pads. They're mystical, magical, and medical. Patients are familiar with them. They're not strange. They're not uncommon. They're not scary. So you just put it on their abdomen and you say, I'm just going to lay this here for a minute. And they'll say, okay. They won't ask why. It's the weirdest thing. Patients don't ask why. And if they do, you give them a non-committal answer like, I'll just need that later. And they'll go, okay. It's weird. If you put anything else on their tummy, they're going to ask why. What is that for? What are you going to do with it? Because remember, they're afraid. Alcohol pads, they're not afraid of. It's weird, but it works. And I'm all about what works. Work smarter, not harder. So let me show you this. Remember, you got to do your opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to take your vital signs. Is that okay? Close curtain, wash hands. Alcohol pad on the tummy. Hold the wrist. Don't find the pulse. Just hold the wrist. Look at the clock. Say start. Count the respirations until the minute is up and then say stop. Do your closing. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean. Bed's in low position. Open the curtain. Wash hands. Document. We counted something. We got to write it down. What do we do after we document? Wash hands again. That's the whole skill. Okay. Good. Go ahead and play the video. See if you can get his respirations.
Hello?
Hi, Mr. Mr. Jones. My name is Patty. I'm your CNA today. How are
I'm
you?
doing great.
Wonderful. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, this will take me about a minute. I'll let you know when I'm done, but I will need you to remain quiet during this time.
Okay.
I'm just going to lay this on your stomach for just a moment, okay? Ready? Start. See how that alcohol pad helps you see the respirations? Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you would like anything, just let me know. Can I get you a magazine before I go?
No, thank you.
Okay, I'm going to open your curtain and wash my hands and then document. Okay, now I'll document my findings. I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. Remember, you have to wash your hands after documenting too. Okay. Questions on that one? Questions on that one?
I'm kind of confused, like how you count it.
Okay, so I'm going to breathe real quick, and I'm going to use my fingers because I can't talk and breathe at the same time and you be able to see. But let's look at the clock here, and let's pick a starting point. So I'm going to start when the second hand gets to the 10, or when the second hand gets to the 12. I want you to watch my chest and count how many times I take a breath. Okay, ready, set, start. Stop. That's how many breaths I took. Did you see me breathing? That's all I did was count how many breaths I took.
How do you count and then also look at the clock at the same time?
Okay, so did you notice how long it took me to take a breath? It's a long time. That's a long time. So you glance at the clock. Don't stare at the clock. Just glance at it. Now, we know normal is between 12 and 20. So I probably don't even need to look at the clock until I'm at like 9 and see how close I am to my minute. I don't have to stare at the clock. What I want to do is focus here. And then just occasionally glance up there to see.
And then, sorry. And then
You're good.
If you like, let's say you look at the clock and you look at it and it's like 0.5 seconds off and you counted 10 and it's supposed to be 9.
Okay, so you can be off by 2 breaths in either direction.
Okay.
So let's say the evaluator got 16. That's what the evaluator got because they're counting at the same time. If you got 14, 15, 16, 17, or 18, you're good. I mean, that's a huge margin of error. But as far as the time goes, we started with the second hand on the 12. If we ended with a second hand on, like 2 seconds after the 12, that's okay. That's all right. What they're looking for is, are you counting for 15 seconds? That don't do that. We're going to get it as close to a minute as we can. But if you're a few seconds off here or there, it's okay. You're new at this. Remember, it's entry-level skills testing. You're new at this. Over time, you're going to get really, really good at measuring a minute. Really good at it. Okay? Questions?
How many skills are you going to do at the test?
3. So if you look at page 25 in your skills book, those are all of the skill sets that they use in testing. Page 25 shows you all of the skill sets they use. All right, so we're going to switch gears now and talk about test registration. You guys all have test registration packets in front of you. And I have a whole presentation on my website about this because you're going to want to review this after we're done. If you go to my website, 4YourCNA.com, you want to look under testing because this is test related. Under testing, you'll see test registration instructions. You will probably want to refer back to this if you have questions. So let's get into this. This is the first page that you see. This page right here. This tells you your steps that we're going to take to register for the test. There's 4 steps involved. You can see at the top of each column, 1, 2, 3, and 4. Oops. The first step is to get your background check. If you don't already have a level 2 photo-enabled background check, you need to get one. And it has to be for medical. So if you worked in the daycare industry and you got a background check, it does not work for this. If you worked in finance and got a level 2 background check, it does not work for this. If you were a security guard and got a background check, it does not work for this. It has to be medical. And that's because, according to Florida state law, industries cannot share background checks. It has to be industry specific. So if you don't have a level 2 photo-enabled background check, you need to go get one. That means that you're going to make an appointment somewhere. You're going to go to that appointment. They're going to take your fingerprints. They're going to take a picture, and you're going to sign. They get your signature. And then they're not going to give you anything. They do not give you your background check. They transmit it electronically to the clearinghouse. You're not allowed, it's called chain of custody. You're not allowed to physically have your background check and submit it because in between, you might get it into Photoshop and change a few things. They send it to the clearinghouse. The clearinghouse is the medical filing cabinet for all medical background checks. So that means when we go do the background check, we're going to have a code. That code is going to tell them where to send your background. That code is in this first column. The gray box here has an ORI number. You need that ORI number when you go get your background check. If you don't use that ORI number, it won't go to the right place and they won't be able to find it. So this box right here, super important. Super important. Now, where can you go get a background check? There's lots of different places. The sheriff's office does do them. My last class, though, several people went to the sheriff's office and we had a problem and a delay. So they're a lot cheaper at the sheriff's department. It's like $35 or something. Understand that if you go, the last class had a delay. If you go to this website up at the top here, Deontis, if you go there and do the background check, register for a background check there, it's a little more expensive. It's like 70 something dollars. And they do it at the UPS store at Barclay. But the people that went there didn't have a delay. So I don't know. I'm hoping that the sheriff's department gets better at this. I don't know. All I know is no delay here, but more expensive. Delay at the sheriff's department, but cheaper. So figure out what works for you. All right. So if you go to, we're going to talk about how to register for the background check right now, but all of this information is on prometric.com/nurseaid/FL. And again, that's on that sheet. You have this website on that sheet. When you go there, under candidate resources, you're going to see a list of fingerprint vendors. If you don't want to use the one that's on this sheet, you can find out who else you can go to. There was a woman who offered to come in here and do fingerprints for classes, get all of you done at one time, but she was going to charge like $110 a piece. That's too expensive. So there are other places to go, but you're going to want to price check because some of them are a little more expensive. If you use Deontis, it's a little confusing. Their website's a little confusing. So let me walk you through it real quick. Remember, you're going to get a link to this video. You are going to get a link after class today to this video. At 12:42 is where I'm going to go over the background check. So you can fast forward to this part to review this if you need to. Okay. So if you go to deontis.com, you got to create an account. You got to have one of those super secret passwords that has a letter, a number, a symbol, a capital, all that stuff. Once you register for an account, it's going to bring you to this screen, and this is where people get lost. What do I choose? Well, we're going to do Florida services. That's what we're going to choose because CNA is a Florida state regulated industry. You need that ORI number that we just talked about, and we're going to put it right here where it asks for our ORI number. Once you do that, it's going to bring this screen up and it's going to say CNA by exam, and that's what we want. Good. So we're going to hit next. When we hit next, we get to this screen, and this is really confusing. There's a drop-down box. It says reason for request. And you want to go to the very last one. It says other employment and licensing. Licensing. And then we're going to leave the OCA blank. We don't need that. And we're just going to put all of our information in. Your name, your alias, your address, your social security number, all of your information. And then it's going to bring you to this screen where you get to choose where you want to get the background check done. Put your zip code in. It'll bring up a UPS store close to you. It tells you can choose a day to make an appointment, and they do same day appointments. So you can get it all done today if you want to. Once you do that and you make your appointment, you're going to get your payment screen. Right now, it's running $76 through Deontis. You'll put your payment information in, and then when you go, they're going to take fingerprints, picture, and signature. Once you go to that appointment, you go home. They're not going to give you anything. You don't have to send anything anywhere. Just go to this appointment, and then you're done. Now you can register for the test. Good? So let's get into that. So step 2 is registering for the test. Now, we got 2 different ways of doing that. We can either do online, which is this website that we talked about. The link is right there. Or this paper application that you're physically holding in your hands can be mailed in to this address. Mailing it in takes longer, obviously. Prometric's website does have a contact us section, but they just redid their website and it's a little hidden. So you'll probably want that information. And then this is under application process is where you would find your online application. The online application is exactly what we're filling out, just online. So let's look at this registration form. So if you look at the top, it says Florida Certified Nursing Assistant Exam Application. This is what you want to fill out. Make sure you're registering for the CNA registration form. Read all of this, answer it appropriately. But the biggest thing, that stop sign, the biggest thing that you need to know is the name that you put on this registration form has to match the name on your photo ID exactly. So if you have more than 3 names, a first name, a middle name, and a last name, this can get a little bit tricky. You have to look at your ID and see, is it hyphenated? Are both names listed? So pay attention to your photo ID. You'll also need a secondary ID that has the same name. That could be your Social Security card or something with a signature. Once you've read through all of this and you have your 2 forms of ID and you know what name to put on your registration, we're going to come down here and complete our demographic details. Now, you can do this on your own. We're not going to fill this part out together, but we are going to fill out some of this together, the things that I know you're going to have a problem with later. So let's go to page 2 of the registration form. This is the rest of your demographic information.
I just have one question. On the first page, it has like the days in between. So is it saying I should wait 2 or 3 days after getting my background check to apply for?
You don't have to, but that's kind of ideal. Okay. Just especially if you're using the sheriff's department, because it does seem to be a little bit delayed. So let's go down here to the bottom of page 2. Everybody with me? Where it says criminal and Medicaid, Medicare fraud questions. Everybody in the right place. This is so confusing for students. This section has to do with Medicare, Medicaid as a provider, not as a user. So if you've ever been on Medicaid or Medicare as a patient, that has nothing to do with this. This section is all about, there have been a couple of doctors that got caught committing Medicaid and Medicare fraud, where they overbill or they bill for procedures they never did. If you worked for that doctor and you were put on a list that says you can't ever work in medicine again, that's what these questions are about. Good? Make sense? Okay. Question 1, though, has to do with your criminal history first. So question 1 is asking if you have a felony under certain statutes. If you have a felony in your background, you need to see me after class. If you have no felonies in your background, put no for number 1.
For all the ones under number 1?
No, just number 1. Put a no, put a check mark in no. I want you to skip A, B, C, D, and E. Do not answer those. You only answer those if you check yes. Don't check yes until you see me after class. So skip all of those. Go down to number 2. If you don't have a felony in your background, check no for number 2. Go to the next page, skip A and B. Now, if you've never worked for a doctor that got caught with Medicare or Medicaid fraud and you've never been told you can't work in medicine, you'd have to go to court, you'd be on a list, you'd know. If none of that applies to you for 3, 4, and 5, check no. Don't check A's, B's, C's, or D's. So felonies in your background, see me after class. If you have no felonies, 1, 2, 3, 4, and 5 should all be no. Nothing else should be checked. Good? Disciplinary history. Guys, what they're asking here, have you ever been a CNA or medical professional in Florida or any other state and got your certification taken away because you did something bad? If the answer is no, the answer is no. All of them are no. I actually had a student that got caught by this. She had been in occupational therapy in another state, didn't tell me. She had an inappropriate relationship with a patient and was sanctioned, got her occupational license suspended in the other state. She moved to Florida, and she did not declare it on here. And she had to go before the Board of Nursing to explain why she lied on her application. So that's what this is all about. Come down to criminal history. This is easy. You either have one or you don't. Yes or no. Criminal history, yes or no. The second question there is, have you had a juvie record? So the second question would be record sealed. That's a juvie record. Or expunged. I'm sorry, the second one is sealed or expunged. The third one is juvie. We were all young and dumb. You do know that, right? Everybody was young and dumb, just not everybody got caught. They aren't going to hold it against you if you did, but they do want to see patterns. If you had one shoplifting charge 10 years ago, you've been good ever since, they don't care. If you got 10 shoplifting charges and the last one was 2 weeks ago, they care. See the difference? They give second chances. Page 4, you fill this out. I cannot help you with page 4. The health history, we are not allowed to give you guidance on. You read the questions and you answer them. I cannot influence you in one way or another. Let's go to page 5. This is the most important box on this registration packet, and I've already checked it off for you. So if you look at the top of page 5, it says certification option eligibility. You guys all there? Everybody should have E3 already checked off. Do you see that? If you register online, you have to make sure you check E3. Anything else here will delay or prevent you from testing. E3, the most important box on this registration packet. Now, I've X'd out training information because we only fill that in if we answered E1 or E2. What did we choose? So that does not apply to us. Come down to test site information. Okay, if you've had, have you had it since 2002? Okay, if it was before 2002, doesn't count.
I'm honestly not sure.
If not sure, just do challenge. All right, so down here in test site information, we're all going to test at a regional testing site. Regional test site. Pull this out. Now you got to tell Prometric where you want to test. Florida is a really big state, and you don't want them to assign you to a testing center in Jacksonville if you live in Spring Hill. That's a long way away. So you've got to tell them where you want to test. This in the front of your packet are all of the testing centers in Florida. We are in Central Florida. Down here at the bottom, the very last one on the first page of testing centers says Agilus. That is our closest testing center to us? It's, if you take the Parkway down, it's by the airport. That is our closest testing center. Those of you that live in Citrus County, you may want to test in Ocala. That may be closer to you. You can see that there's a couple of testing centers in Ocala. So you want to look at whatever's closest to you and choose that testing center. There's a code beside it. There's a code. You're going to put that code where it says test site code. If you're going to mail this in, you need to put the code. If you're doing this online, though, it's a drop-down box. But the drop-down box just has names. It doesn't tell you where they are. So you need this to find out the name and where it is so that you can choose the right one in the drop-down box. Good? Questions? Okay. So once you've checked off regional test site, put the test site code in here. Again, you can find the test center list online on prometric.com/nurseaid/Florida. They got the whole list here. This is what theirs looks like. I put it on 2 pages to make it a little, and split it into divisions to make it easier for you. This doesn't really help because they're all scattered everywhere. So I made them more specific to our area. All right. So once we know what tests we're taking, challenging, where we're going to take it, now we have to tell them which test we want. And yes, there are options. If English is not your first language, if you'd rather take the written test in Spanish, you have that option. You can take the written test in Spanish if you want to. That's going to be down here toward the bottom. If you want the computer to read the test question to you, that's called oral testing or with audio, and you'll see that up here. But most people, the skills have to be done in English. There's no way around that. Skills have to be in English. Most people just choose the first one. It's just your regular skills test, your regular written test on the computer. If you want audio, if you want the computer to read it, it would be the second one. If you want it in Spanish, it's going to be down here. If you fail, and my students don't, but if you fail, you would only have to retake the part that you failed. So if you failed the written, you just have to retake the written. That's right here. If you failed the skills, you only have to retake the skills. That's right here. But my students don't have to worry about that. Good? So the first one is what you should, most of you should check. And you'll notice that that is $155. So over here to the side, we're going to write $155. And in a minute, we're going to tell them how we're going to pay. Up here at the top of page 6 is an affidavit. Now, this affidavit says that you have these 2 pages. This is the FBI background check privacy policy. It tells you how they're going to use your information to clear you for testing. So when you check this box, it says, yes, I have received that paper. I've already put it in your packet for you so you can check yes. Read the attestation, sign, and date. At the bottom here, it tells you if you do not receive your authorization to test in 10 to 14 days, you need to call Prometric. How long do they say? When you call Prometric, they're going to tell you it can take up to 6 months to clear you for testing. What does your application say? So you tell them, my application says 10 to 14 days. I'd like to speak to a supervisor, please. That is how you get through to somebody who knows what they're talking about. Because the people that answer the phone, their whole job is to get you to get off the phone. They will tell you a stock answer that does not have anything to do with your test, because Prometric does testing for a lot of industries, not just CNA. Good. So what does your application say? Ask for a supervisor. And then the last page is going to be where you, this just tells you about that, 10 to 14 days. The last page will be where you put all of your payment information. If you're doing this online, application is exactly the same, but there's going to be one more box that's not on our paper application. And it asks you, how are you going to provide supporting documentation? What is that? Well, if they have a question about your criminal history, or if they have a question about your health history, or if they have a question about your name or whatever, they're going to contact you and say, hey, we want more documents. They're asking you in that box, how are you going to give them to us? If we ask you for more documents, how are you planning on providing them? By fax or by mail? I don't care which one you pick. Just check a box. Because if you don't check a box online, it won't process your application. Just check a box. Doesn't matter which one. Once you submit your registration, about 24 to 36 hours later, you should get an email from Prometric. And that email, I know I'm running late. Bear with me, guys. That email is going to look like this. This is what the email looks like. You got a little tiny snippet of it here. You want to make sure that right here, it says application status. You want to make sure that that line says complete. That means they got your application, it was good, and they got your payment. They also were able to access your background check. 2 fingers. They also were able to access your background check. If it says incomplete, your application has not started processing yet. You need to find out why. You need to call them. Is it your payment? Maybe it didn't go through. Is it your background check? Maybe they couldn't find it. But you need to contact them if it says incomplete. Now, you'll get another one of these after you're cleared for testing. And then down here where it says pending, it'll actually say approved. Once you get approved to test, this whole packet goes back to Prometric, and Prometric schedules your date. So you'll get one of these. It says complete, pending approval. You'll get one of these when you're approved. It'll say approved. And then you'll get one of these when your test date is assigned. Okay, good. Each one's going to say something a little bit different. All right. Remember, this is the contact information for Prometric, and this is their contract with you. Tells you about how long each step should take. Once you get those emails from Prometric, please make sure you're opening attachments, because your specific information is in the attachment, not the email. Okay, good. All right, you got 2 chapters over the weekend, chapters 5 and 6. Chapter 5 is on dementia. Chapter 6 is a skills chapter. And you'll get a wrap-up email after class today. And remember, you've got your review sheet as well. Any questions on what we went over today? Great job, guys. I will see you on Monday. Have a great weekend and try to have some fun. Those of you joining us virtually, thank you so much for joining us. And we will see you on Monday for class 5. Till then, happy caregiving. Bye.